to the international webinar on burden of disease data to inform policy decision, a case of stroke burden. My name is Hardini Kusuma Dewi, and I'm delighted to be your master of ceremony for today's event. We are so excited to have you with us for this important discussion on how data can drive better health policies in Indonesia and beyond. Ladies and gentlemen, this webinar is organized by the Health Policy Agency, Ministry of Health of the Republic of Indonesia in celebration of the 61st National Health Day. Today, we aim to strengthen our understanding on how burden of disease, especially stroke, can guide stronger evidence-based health policies for Indonesia. To begin our session, let us hear the report from the organizer, Bapak Lupi Trilaksono, SFMM APT, Director for Health Resource System Policy. Ladies and gentlemen, it is now my honor to invite our keynote speaker, Professor Asnawi Abdullah, Director General for Health Policy, Ministry of Health of the Republic of Indonesia, to deliver the opening remarks. Professor Asnawi, you may have the screen.
Terima kasih Mbak Hardini. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat pagi, salam sejahtera bagi kita semua. Good morning and very warm welcome for all of you. It is an honor and privilege to welcome our distinguished guests and esteemed colleagues to this important gathering. We are especially grateful for the presence of our international partner and distinguished expert from the World Health Organization, Institute for Health Metric and Evaluation, National Institute for Stroke and Applied Neuroscience, AUT University Auckland, and the World Stroke Organization, as well as our valued expert and colleagues from international institutions across Indonesia. The honorable guests from the ministries and cross-sectoral agencies, local government, professional organization, development partner, academia, ladies and gentlemen. First and foremost, let us offer our praise and gratitude to Almighty God for His grace and blessing. We are able to come together virtually today in good health to attend this international webinar commemorating 61st National Health Day on November 12, 2025. The National Health Day is an important moment for us to reflect on the progress and the challenges in Indonesia health development. In line with the ongoing health transformation agenda, evidence-based policy making has become an absolute necessity. One of the sources of evidence is the burden of disease data, which provides a comprehensive picture of mortality, morbidity, disability rate in our population. This webinar highlights the issue on the stroke disease burden. As we know, stroke is one of the leading causes of death and disability in Indonesia. Global burden disease data show the hypertension is the primary risk factor contributing to stroke prevalence, accounting for around 7.1% of the total disease burden in our countries. It is equivalent to the loss of 6.7 million years of healthy life, or DALI. This is a burden confirmed by 2023 Indonesia Health Survey or Survey Kesehatan Indonesia SKI, which found that 30.8% of Indonesia adults have hypertension, a condition that becomes more prevalent with increasing our age. In addition to hypertension, other major risk factors for stroke include diabetes, affecting 11.7% of our adults, smoking with a prevalent 29.7% among adults, and low physical activity also reported by 77.4% of the adult population. These updated figures underscore the urgency of adopting sharper and more effective intervention from health promotion and from prevention to strengthen primary health care and also referral care services. In response to this challenge, the Ministry of Health has launched free health screening program or Cek Kesehatan Gratis CKG or PKG as a strategic initiative to enhance early detection, to enhance screening of non-communicable diseases, including risk factors for stroke such as hypertension, diabetes, and high cholesterol. CKG program provides free health check at over 10,000 primary healthcare or puskesmas across our countries, and 146,000 schools targeting individuals across all age groups. Since its launch in February 2025, the program already covered about 50 million citizens. This massive outreach reflects a growing public awareness of the importance of preventing health measures and underscore our commitment to building a more resilient and equitable our health system. By identifying risk factors early, the CKG program can play essential role in reducing the long-term burden of stroke and other non-communicable diseases on individual, family, and the national healthcare system. Distinguished participants, the main objective of this international webinar are to enhance stakeholders' understanding of the concept, methodology, and the importance of burden disease data for health policy making. Through this webinar, we can share best practice in utilizing burden of disease data, particularly for stroke prevention and intervention policies. Most importantly, this webinar also serves as a platform for discussion to produce a strategic recommendation in integrating burden disease data into the national health plan and budgeting cycle. I would like to express my appreciation to all speakers, both international and national, who have devoted their time to share their knowledge and experiences. The presence of experts from WHO, IHME, WHO, leading academician, and our colleague from National Brain Center Hospital, Statistik Indonesia BPS, Ministry of Home Affairs, and BPJS Kesehatan will greatly enrich today's discussion. We would also like to extend our gratitude to 100 participants joining this webinar. I see various backgrounds such as policymaker, academician, health practitioner, professional organization, and development partner. I hope your active participation is the key success of this event. We hope that the outcome of this webinar will not only increase our knowledge, but also result in concrete policy brief accessible to the public, and also foster stronger networking among experts and institutions who are working in this area. Finally, let us make the best use this forum to collaborate toward advancing a better and stronger Indonesia health system. In the name of Allah, the most gracious, the most merciful, Bismillahirrahmanirrahim, I hereby declare the international webinar entitled Burden of Disease Data to Inform Policy Decision, a Case for Stroke Burden, officially open. Thank you so much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Professor Asnawi, for the inspiring message and for setting the direction of our discussions today. We will now proceed to the first panel session, focusing on the influence of risk factors on burden of disease and lessons from disease registries. This session will be moderated by the team leader of Policy Health Resources Integration, Ibu Dr. Sri Wahyuni, Master of Science, with our distinguished speakers from WHO Western Pacific Regional Office, Vital Strategies, and National Brain Center Hospital, Jakarta. Ibu Sri, you may have the screen.
Thank you very much, Ibu Hardini, for introduction. I would like to kindly invite our guest important speakers. We have Dr. Lubna from WHO Indonesia. Welcome, Dr. Lubna. Thank you for joining us. And we also have important person, Dr. Reza, which is coming from the National Brain Center. And also Dr. Lin should be able here, but he's not changed her profile name yet. But I believe Dr. Lin, are you ready? Dr. Lin is coming from the Vital Strategies.
I'm ready.
So without further ado, let me invite Dr. Reza Aditya Arpandi from National Brain Center to go first of this panel one. Let me try to read his brief summary of the important profile. Dr. Reza is a medical and nursing director at the National Brain Center Hospital in Jakarta, a leading institution in neurological care with extensive experience in diagnosing and managing complete neurological condition. Dr. Reza actively engaged in clinical research and healthcare innovations. Dr. Reza career reflects a deep commitment to both medical excellence and organizational leadership, combining medical expertise with strategic leadership to improve quality, efficiency, and patient-centered services. Dr. Reza, you have the first screen.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Suara
wabarakatuh.
saya terdengar jelas, Dr. Sri?
Agak jauh dong.
Sudah jelas, Dok?
Sedikit lebih baik, tapi mungkin boleh mendekat lagi, Dok, speakernya. Ya.
Baik, suaranya jelas, Dok? Oke.
Masih kecil ya, Dok ya?
Masih kecil ya suaranya? Oh, oke, baik. Tunggu sebentar dong. Oke, kalau sekarang dok?
Yeah, better, Dr. Reza.
Alhamdulillah.
Okay, that's good.
Yeah, thank you. Dr. Sri, thank you so much for your very kind introduction, Dr. Sri. And thank you for the opportunity that is given to us from National Brain Center Hospital to present about the stroke registry in Indonesia. So my name is Reza Arpandi. Currently, I'm the medical director of the National Brain Center Hospital, RSPON, and also the lead for the stroke transformation program atau program pengampunan stroke, Bapak Ibu. And today I would like to share our journey in developing the Indonesian Stroke Registry with the Ministry of Health, of course, and how we try to move from the fragmented hospital-based data to a unified digital registry that is integrated with our national Satu Sehat health platform. Slide. So this is the overview of my presentation. Slide. Stroke has been the leading cause of death and disability in Indonesia for the past 20 years. And based on the global burden disease data, stroke accounts for around 7% of total daily lost. Or roughly, it's about 6.7 million years of healthy life lost because of stroke. And its prevalence have also increased from 7 per 100,000 in 2013 to 10.9 per 1,000 in 2018. And these numbers show how crucial it is for us to have a national standardized data system that can track stroke cases and outcomes across the country. Currently, we want to know what is the mortality rate of stroke in Papua, or what is the mortality rate of stroke in Aceh. We don't have the current data. We need to track each region manually. And of course, this is time consuming. And if we have a very good data that can be tracked, can be accessed remotely and then can be tracked up-to-date data, then of course the policy making will be easier. Right? And that's where the Satu Sehat stroke registry comes in as part of our move toward data-driven and evidence-based policy making. Right? So why stroke registry matters? So before this initiative, data collection on stroke was very fragmented. Each hospital or each association, professional society, such as the Indonesian Neurological Society, have their own registry. And it was not standardized and making it difficult to compare the data between each hospital. And the National Registry under Satu Sehat addresses this by connecting all of the hospitals under one platform, one interoperable platform. So hopefully the data consistency, the real-time monitoring, and direct linkage with our national health policy systems will be easier. Slide. So our journey toward a national registry started modestly. So before 2018, we have independent registries. This is independent hospital or society-based registries, and the data is not yet standardized. And in 2019 until 2020, our hospital, National Brain Center Hospital under the Ministry of Health, tried to develop a registry, but it is still manual. We have a person that's responsible for inputting the data manually for each patient. But now we have moved to the integration of this data with our electronic medical record. And from 2021 until 2023, we expanded the stroke program, the stroke transformation program, atau program pengampuan stroke. And this program is connecting all of the hospitals into a structured network. And in 2024, we are entering the digital integration phase through Satu Sehat, and hopefully from the 2026 onward, we plan a full national rollout for the expansion of the stroke registry. Slide. So I would like to tell you a story first about this transformation program that we have. Slide. So the stroke transformation program is the foundation of this network. It is a nationwide initiative led by the Ministry of Health to strengthen the stroke care capacity across all levels, from the national hospital to district hospitals. And it focuses on 5 pillars: the collaboration and networking, setting up regional centers of excellence, mentorship, doctorship, training, and virtual case discussions. We also defining the key performance indicators, and finally building a national stroke registry. And this registry serves as the digital backbone for the entire transformation. Slide. So our network of stroke transformation program connects comprehensive hospital at the top tier. This is a Paripurna hospital, comprehensive hospital. And connecting this hospital, we have 13 centers of regional excellence hospital, or we have 13 comprehensive hospitals. And these 13 hospitals are connected with the provincial and also the district hospital. And this network is not for referral of patients, but to network of education, network of training, to transfer of expertise, ensuring that each hospital, no matter its location, can manage acute stroke care effectively. And this tiered system help expand access to life-saving interventions. We focuses on thrombolysis and thrombectomy. Thrombolysis has only been approved by our national insurance, or it is only been covered by the national insurance in 2022, and thrombectomy as well is only been covered by our national insurance in 2023. So we need to set a standard across all of these hospitals how to have proper stroke care for thrombolysis, thrombectomy, and also having a stroke unit, a good stroke unit. Slide. And through this transformation, we've already seen substantial progress. The number of hospitals capable of performing thrombolysis increasing from 2021 until 2025. And the number of thrombolysis, it increased 4 times since the project started. And also the thrombectomy, since we started in 2021 until 2025, the number of thrombectomy has also been increased 2 times, doubled. And we also define the KPIs for acute stroke quality. The first is the door to CT within 30 minutes. And the second was AFib thrombolysis within 4.5 hours. And then the length of stay for stroke patients must be under 7 days. And the mortality rate in this hospital is targeted to be less than 10%, the mortality rate in this hospital. Slide. And that's where the Satu Sehat registry comes in. So, slide. The registry operates within the Satu Sehat ecosystem. The national health data, Satu Sehat is the national health data integration platform. So data from hospital, EMRs, or from CMS, dari rekam medis elektronik Bapak Ibu, flow directly into the Satu Sehat API, and then this connects to the national dashboard for policy analysis. And this setup eliminates, so there will be no more manual reporting, minimize duplication, and hopefully this ensures that clinical data can be accessed in real time. So we can see what's the mortality rate in Papua, in Aceh, what's the KPI, what's the KPI, the indicators, how do they perform in Aceh, in Papua, in Makassar. And this data can be accessed by the hospital administrators and also by the Ministry of Health, by the policymakers. Slide. So we are currently in the pilot phase involving 10 hospitals across Indonesia. Each hospital tested data transmission using the Satu Sehat playbook. Slide. So the Satu Sehat playbook covered 40 standardized variables, and the result was a 100% success rate during the testing on the staging server. And this pilot is very critical to validate the system readiness before full deployment. And before we utilize this as a disease full disease registries in Indonesia. And also this can be function as a model as well for other disease registries in Indonesia. Slide. And the registry collects data across 7 main domains, from socio-demographic information, risk factors, admission details, neurological examinations, the severity of the stroke using NIHSS score, NIS score, and assessment of the dysphagia, and also the diagnostic that is being used, CT, the result of CT, CTA, MRI, and the laboratory results, and also the treatment and discharge outcomes. So these comprehensive structures allows us to analyze not only the acute management performance, but also the long-term outcomes and patterns in the care delivery. Slide. And the national dashboard tracks 10 key indicators. The first one is stroke incidence, prevalence and incidence. The second one, mortality, and then the treatment timeliness, and also survival rates at 3 and 6 months, among others indicators. And these indicators will be used not only for reporting, but hopefully for benchmarking and also for policy making. Slide. So the implementation phases and timeline. Hopefully, the registry will go live in December 2025, and this will be giving us a real-time data feed to Satu Sehat platform. Slide. And then we try to see what is the how to link between the evidence to the policy. Slide. So this registry is grounded in the burden of disease framework, linking patient-level data and then to national epidemiological metrics. And it allows us to connect clinical performance with the population-level outcomes, which then can inform us about the budgeting and how to deal with the resource allocation, also with national planning. Slide. As in practice, this registry data, first of all, can be used to benchmark hospital performance, comparing a hospital that is in Aceh, comparing with the hospital in Papua. What is their door-to-needle time, and what is how is their length of stay in those hospitals? And then the impact, we can improve the workflow efficiency between these hospitals, comparing with the top-tier hospital and then comparing with the hospital that's located in the district, in the cities. And this can also guide the resource allocation, where we can prioritize the provinces with high burden of diseases. And also we can do this for targeted intervention design. We integrate this with BPJS data and also BPS data. And also we can use this for predictive analytics to see which patient that may have secondary strokes and which area that will probably have more strokes in the next 10 years because those area have more hypertensive patient, more diabetic patients. So this is the sample of use cases that we can do with a proper good registry data. Slide. And we are also aligning our efforts with the WHO, with the WSO, and also with the IHME data. And our goal is to ensure that Indonesia's data contributes to the global stroke surveillance. And hopefully our experience can inspire other countries building similar digital health infrastructures and also improve their national stroke care. Slide. And of course, we have challenges. And this is what this is the challenges that we face, that we have. Slide. The most significant challenge that we have is the variation in hospital information systems, limited IT resources in regional areas, and this may hinder the completeness of the data. But these challenges will be addressed through mentoring, national coordination, also capacity building efforts. And hopefully all of the hospitals will have the same infrastructure, will have the same resources that can so that this registry can be implemented nationally in Indonesia, in all hospitals in Indonesia. Slide. And we've learned that success depends on close collaboration between the clinicians, between Nakes, NAMED, and also the IT teams. So continuous monitoring and also mentoring and also with real-time validation, very critical to maintain the data quality. And above all, the leadership at the hospital level and also at the district level, the role of the Dinas Kesehatan Kabupaten, Dinas Kesehatan Provinsi, is very crucial to sustain this initiative. Slide. So looking ahead, we plan to expand the registry to all 34 provinces, and hopefully we can integrate rehabilitation and also primary care modules and develop AI analytics for early detection and outcome. Slide. So to conclude, Satu Sehat Stroke Registry is more than just a data platform. Satu Sehat Stroke Registry represents Indonesia's commitment, our commitment to build an intelligent, interconnected health system. So the upcoming pilot involving the 10 hospitals, this will test our readiness to integrate the data for digital integration. And our success will depend on integration, the quality, and also sustainability of the system. And our vision is to turn from evidence, from data, into action, and data into better, hopefully will be a better outcomes for our patients, especially stroke patients nationwide. And thank you. This is the last slide, and we are very thankful that this webinar is here and to present you about the data, about the registry that will be used to implement the policy changes across all of Indonesia. We're also going to hear from other experts from WSO, from the IHME, and hopefully we can learn and implement this in Indonesia. Terima kasih sekali lagi Bapak Ibu. Saya tutup. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Reza, for the important presentation, because it's like important message where you talk about the transformation, reform of the policy on stroke and registry and management. Thank you. But please stay there. We are going to have a question from the participants. But we would like to have the second presentation, which is also important, from the WHO Indonesia. We have Dr. Lubna Bati. She is a team leader for non-communicable diseases and healthier population at the WHO Indonesia. Dr. Lubna is a physician and epidemiologist with over 25 years of experience in public health. Since 2022, she has led the NCDs and healthier population team at the WHO country office in Indonesia. In this role, she oversees portfolios related to NCDs, prevention and management, environmental health, climate change, maternal, newborn, and child health, as well as social and economic determinants of health. So I give the floor to Dr. Bati to deliver your presentation, please.
Terima kasih, Ibu. Ibu Bayu, can you please confirm if you are able to see my slides?
Yes, it's sharing, but it's not showing. I mean, you need to click the slideshow button. Yes.
Can you confirm? Because I'm working from one screen. It's
Yes, that's perfect, Dr. Bati.
Okay, perfect. Good morning, Assalamualaikum, Selamat pagi, everyone. Thank you, Ibu Bayu, and the colleagues at BKPK to inviting us on this wonderful webinar. And it's a tough act to follow after what Pa Reza already spoke about. But I will try to spend the next few minutes talking about stroke, the risk factors, what's the disease burden, and what are the management strategies around this. And the reason I'm doing that, I'm slightly because I'm always wanting to use every opportunity for an important public health plug from our side. As Pasnavi said, I think it's a continuum of care for stroke, which is from promotion, prevention, management, and rehabilitation. So very glad to be here. And so in the next few minutes that have been allotted to me, I would like to spend a little bit time. Some of these demographics have already been touched upon, but it's good reminder to us is, what is the transition in disease burden and what's the significance of stroke prevention, which is under the umbrella of NCD prevention. What are the key risk factors which are contributing to stroke, and why it is important that we take action in Indonesia? What are the technical packages for reducing the burden, and then looking at a couple of recent products that have come in, and what are our critical data focus areas, and I will be touching upon that. So, as colleagues have already said before as well, is stroke is the third leading cause of death worldwide after ischemic heart disease, and in recent years after COVID. And these deaths have only gone up in over the last couple of decades. If you look at this slide, this tells us how over the last few decades, the burden of diseases have changed. From communicable diseases, now it's the and non-communicable diseases which are killing people. Every year, 41 million people lose their lives to one or the other non-communicable diseases, and it's 75% of all deaths across the globe. Of these, almost half, or 17 million, are premature. That means they happen before the age of 70 years. And while we all have to die, these deaths are premature, which means these deaths are a loss to an individual in their productive year, to a family, and also to their community and their country. Most of these deaths are actually happening in low-income countries, which again increase the burden at the individual level, but also at the country level by increasing the expenses, but also also impacting livelihoods. And 80% of these deaths are actually linked with cardiovascular deaths, cancer, chronic respiratory diseases, and diabetes. Now let's come to stroke. What's the burden of stroke? And I know it's been mentioned before, but during this 20 minutes that I've been allotted, 600 people will die from stroke. And in Indonesia alone, it's approximately about 15 lives which would be lost in the same time. Every life is precious, and that's why we need to make sure that we are doing our best in public health to prevent them and to make sure that people are able to enjoy their health to the fullest. And just a quick refresher, I always believe in refreshers, and I know it's a public health game, but it's good to have some definitions clear. Stroke is actually also referred as brain attack. It happens when either the blood vessels get blocked in the brain, or they rupture, which leads to a lot of bleeding and damage to the tissue. The severity happens on the affected brain area and the extent of blockage. As a result, as what Pareza was saying already, it is so important for us to know and get the care immediately, because brain needs blood supply, and every second lost is going to have an impact. As a result, it has a high risk of death and even a greater risk of moderate to severe disability in the people who survive a stroke. And not to mention that it increases the risk for future strokes in survivors as well. So What are the risk factors? There are some non-modifiable risk factors which we cannot change, which is our age, gender. Women are more likely to have strokes. It's sometimes links with because they have slightly higher life expectancy. As we grow older, our blood vessels become more firm, less pliable, obviously increasing the risk for stroke. Family history has known to play a role in it. And as has been said before, a prior stroke or an existing cardiac or kidney condition also impacts. But is all lost? No, there are a lot of modifiable risk factors. And here is a list that I have actually borrowed from the latest Global Burden of Disease report on stroke. And you can, these risk factors could be divided into these 4 categories. It's highly preventable, and 80% of the stroke burden was attributable to these risk factors, for which we, as a collective global public health community, have several interventions which have proven to work. In behavioral risk factors, the biggest one for us is tobacco smoking, and also the exposure to secondhand smoke, alcohol use, and low levels of physical inactivity. Diet plays a big role. Diets which are high in sodium, red meat, and processed meat are risk factor. At the same time, diets which are low in fruits and vegetables and whole grain, with meaning less fiber going into our system, are also a risk factor. There are metabolic risk factors like overweight, obesity, which gets reflected through high BMI, diabetes, hypertension, increased lipid levels in your blood are metabolic risk factors for stroke. And something new that's also coming up, and I think it's of key importance for Indonesia, is the environmental risk factors, including the ambient and air pollution, and some of the recent work that has been happening around suboptimal temperatures. So I think that's a key area for us to look at, and in terms of the data gaps that we have. So why is stroke prevention important for Indonesia? It has continued to be a leading cause of death. While there have been improvement in other areas of work, in Indonesia, stroke continues to be the first cause of death across over the several decades. And at the same time, while the health expectancy has improved for us, which is fantastic, at the same time, our demographic structure in Indonesia is changing. We are going to be having a lot more people who are elderly, as Pas Navi said earlier. And as I said before, age is a non-modifiable risk factor. So with an aging population, how do we prepare better our health systems so that we are able to prevent as many cases of stroke as possible, and at the same time prepare our health systems to be to foresee the burden and improve our services and other aspects of health systems to manage this load. Cardiovascular diseases are also causing the major health expenditure in Indonesia. This is some data that we have from BPJS, the National Health Insurance System. I don't have the latest data, but from in the system, when it was in the first year of inception was 2014, and in the first 5 years already you could see that the expenditure for stroke-related expenses and services increased from 0.74 trillion Indonesian rupiah to 1.2 trillion in 2018. And I know the latest numbers are much higher, and I'm sure Pika colleagues and BPJS colleagues who are coming in the next panels would also speak around it. And the spending is at this point mainly been on curative and management services. So what does that mean for us for the for modifiable risk factors? You remember the previous slide that I showed you, And now what is difference between the previous slide and this one is you see some text which is highlighted in red. So there's a great paper that has come out in Lancet in 2024, which is from the Global Burden of Disease Study on Stroke, where they have looked at all these risk factors and have looked at the burden of disability-adjusted life years for Indonesia across these 23 risk factors. The one in red are the ones where we are seeing really a lot of significant change. And I think these are the areas to keep looking at and to make sure that we have data that are available where we are able to look at how we are doing across a spectrum of public health services, but what are our changes. So for the next couple of slides, I'm not going to go through all of them, but I have taken the liberty of taking the top 2 or 3 risk factors and kind of walking you through where we are in Indonesia on those, and what is it that where data is missing and where we need to look at improving our current surveillance systems and or setting up some new ones. One of the biggest risk factors in the GBD study for stroke in Indonesia was hypertension. And this data is from the SKI, which was done in 2023. For hypertension management, it's very interesting. And again, this data is not super complete. And I think this is an area of work where we are hoping to work better with our colleagues in Ministry of Health to really tease apart that rich data source. So as per SKI, the current prevalence is about 30.8%. However, there's only 8% of persons age 15 and above who are previously diagnosed, aware of their diagnosis. That means they have had their blood pressure measured and they've been told that they have hypertension. However, there was another 30% of people, adults or persons more than 15 years and above, who didn't know they had blood pressure or their blood pressure was raised. And they were diagnosed only when the survey teams went to their home. So we have a big gap in diagnosis, which again with Chikage is a fantastic endeavor and is getting sorted. But what comes next after screening is what is happening on management side. So this is what we call cascade of treatment. And from this graph on the right side, you can see from those 8% who were aware of that diagnosis, although a large number went to ahead and got treated, there's a much smaller number which comes back, almost half of them who come back for routine treatment, and a very, very small number which has actually controlled hypertension. So again, while we are doing a lot of good work around screening, we need to make sure that we are able to look at the cascade of treatment and making sure people who are diagnosed with hypertension correctly are put on the right diagnostics and treatments and are being followed up regularly and are in the controlled range. For diabetes, unfortunately, the data is not as good as we saw for hypertension. The current prevalence is around 11.8, and of those, only 2.2% were aware of their diagnosis. That means they were previously been seeing a doctor. Of these, while a large number of people are put on treatment, there's only very few people who come for follow-up and a much smaller number that is under control. So I think this, again, an area of work where we need to make sure we have the data available through Satu Sehat, through Chekage, through any of the health information systems that are there, and we are able to integrate them to bring them all together. So the health policy makers, the decision makers, whether they are at the national level, the PHOs, the DHOs, the Puskesmas leaders, they are all able to see what is happening in their jurisdiction and where they can take the necessary step. I'm going to use the example of tobacco, which is again another large contributor and a large risk factor for which we have a lot of good data right now, not only for prevalence but also around what has been happening for prevention and control. So in this slide, we are comparing the data from the Global Adult Tobacco Survey. For Indonesia, we had 2 rounds. And the reason I'm using this is because there was a lot more questions that were asked around tobacco compared to the SKI, although both surveys are showing pretty much the similar trend. Overall, we have almost 1/3 of the population which is currently using tobacco. Most of it is smoked tobacco. And there's a big, huge gender disparity here. We have almost over the last 10, 15 years, the trends haven't changed much. We still have between 6 to 7 men out of every 10 men who are males who are using any form of tobacco, mostly it's tobacco smoking. And while for women, it is still at a lower level. But what is concerning for us is now that there are more novel tobacco products like electronic cigarettes, which are now circulating in the market, and from here you can see, I'm using my laser pointer, the current electronic cigarette use has increased from 0.3% in 2011 to 3% in 2021, which is really concerning, because any gains that we've been making previously could be undone by this new tobacco product. This is the data from the Global School Health Survey, which we did in Indonesia in 2023. This is a survey of the 13 to 17-year-old. And here, when you tease them apart, these surveys are done in school, where adolescents are a little bit more free to speak about what is happening. And there you see a much larger and a much more concerning trend. We have a lot more tobacco use happening among our future, which is these young people. Current smoking rates are almost the same. And what is really concerning here is when you start looking at current e-cigarettes among young women. Remember the previous slide where I told you about 15 and above, but here when you start looking at the smaller segment of the population, among women, it is also, among girls and females, it's also increasing. This slide actually talks about, is showing the data, which is for exposure to secondhand smoke. So as I showed you previously, among women, it is the use of tobacco is still very low. But when you start looking at exposure to secondhand smoke, whether you're a smoker or non-smoker, we still have very high rates of tobacco smoking in our public buildings, in homes. So for example, this second set of bars is showing you that although is exposure to secondhand smoke in people's homes. So that means even if the women or younger children are not smoking, they have adults around them who are smoking and contributing to the risk factors and increasing their risk for everything, including stroke. Over the period of time, you can see the red bars are the data from 2021. It has come down, but still 75% in a restaurant, or almost half in public or government building. Is still a very high number. Indonesia has taken great efforts and has made a lot of investment into policies and in also some of health system strengthening structures. This is the history of Indonesia across tobacco control measures, starting in 2007, going all the way to 2024. The darker the color, that means the stronger the enforcement of the policy is. And wherever we have anything in gray area, that means we didn't have the data or we haven't done any action. But this is an area where we have WHO is supporting the Ministry of Health and BPOM and other national institutions in making progress. And we are seeing that in some of the trends. So this is the latest report that has come out in 2025 on estimates of current tobacco use prevalence, and it shows a historical trend data. This is where we are right now, and this is in 2030 is where our SDG goals are. Blue is for men, the green is for both sexes, and the yellow is for women. And the dotted lines are the prediction as with the historical data that has come in form of GATS, in form of SKI, in form of Global School Health Survey. So for me, this graph really speaks on importance of data, looking at which keeps giving us in public health encouragement to move when we see data speaking. So overall, we have had a relative reduction around 5%. So having this data, the current, frequent, comprehensive collection of important public health measures is crucial for us to keep measuring our performance and to make sure that if we need to change any direction in our route, we are able to do that. In the interest of time, I'll just move ahead. So where do we need to accelerate? The global response to NCDs, we are seeing some changes happening, especially around tobacco use with the effort that has gone in. It's globally reducing. However, everything else has been going up. There are only 14 out of 194 countries which are on track to reach the SDG target, and but unfortunately for the rest, we are still behind, but we can still make this work and with some acceleration. So where do we need to accelerate? Here are few areas of work which are very linked with the risk factors that I spoke about for stroke. I think we need to advocate for national actions and national action plans or strategy around cardiovascular disease, including stroke. At the same time, we need to really strengthen our primary healthcare services. We need to scale up coverage of hypertension and diabetes services. So not just looking at screening, but also using that opportunity to really strengthen the cascade of treatment for these areas of work. In Empower, in tobacco, we are making great progress, but I think we need to keep at it and making sure that we have even more stronger policies in place. At the same time, I think looking at where the biggest burden of contribution of risk factor to DALIs in Indonesia is, I think we need to also scale up context-specific actions to look at unhealthy diets, which is reducing sodium and also improving consumption of healthy diets, which are rich in high in fruits and vegetables and grains, and also scaling up the implementation of replaced technical package to eliminate trans fatty acid. In the area of, I don't have a slide for it, but in the area of climate change, WHO is also supporting the Ministry of Health. And as we are seeing from ambient temperature changes and air pollution, I think that's an area where we really need all the sectors to come together and have better data sharing on what are the impacts of, as we are looking at data that comes in from stroke registries. Are we also trying to somehow triangulate some of the data from climate informed diseases and the meteorological data that's coming from those systems? So I think that's an area of innovation that we need to look at. WHO also has the package of essential NCD interventions, which is an integrated approach, which is really important and beneficial when we have low resource setting. And again, all of these contribute to better prevention services for stroke and for reducing the risk of recurrence. And I just want to use this time. I realize, Ibu Vayu, you've been very kind with me. I'm gone a little bit over the minute, but I'm just going to use this time to put a plug in of this product that has just come out, which is the Framework for Care of Acute Coronary Syndrome and Stroke. This is a collaborative effort between WHO, the World Health Federation, and the World Stroke Organization. And what it does is it talks about the care continuum. And the reason why I want to bring that in, and I know Paraza also touched on a little bit on it, is these are all the care continuum includes prevention, but also includes emergency care in the community before transferring to an emergency unit and specialist treatment. So when we are looking at registry, could we also be looking at where we can triangulate some of this data into bringing in our stroke registries? And I am a physician, but I'm also an epidemiologist. So for me, data is very important. And I think what gets measured, gets improved, gets done. So I know the stroke registry has already spoken about it, but I think we need to also look at perhaps a gap in rehabilitation services and connecting that into also in the stroke registries as well. And lastly, I think we need a national plan. I don't think we have one right now, and we will be very keen to support Ministry of Health in building one as part of our ongoing support. And stroke care is not standing on its own. It needs to be part of an overall very comprehensive cardiovascular disease plan. They both go hand in hand. So without taking more time, I think I just want to conclude that NCDs are rising worldwide, and they continue. And even here in our home in Indonesia, it is contributing significantly to mortality and disability. As our population ages more, as there are more shifts in lifestyle due to urbanization, due to changing environments around food consumption and limited mobility, this burden is estimated to increase. We have best practice prevention and management of stroke, which are being implemented, and there's notable progress. However, I think we need to enhance our execution if we want to achieve the SDG 2030 goals. This requires stronger policies for implementation, but also enforcement, addressing risk factors like tobacco and unhealthy diets. We need an increased public awareness to promote lifestyle changes, including health literacy, looking at school education programs, and overall enabling health environment. This also includes expanding access to quality treatment and rehabilitation, including increased coverage, because we have seen disparities across all provinces in terms of access to services and quality services. We need a workforce which is agile, which is ready with the latest tools, latest guidelines, and who are able to deliver using some sustainable and innovative digital solutions. So with that, I close this and I show this picture, which is our future. So I hope we are able to make some key action today in our discussions, where we can use data to make our case to the policymakers and to the public health professionals to see how do we keep tracking the progress that we need to make and identify the gaps and keep filling them with the rich data that is already available in Indonesia, and just some new ones that we need to identify. So, Ibu, with that, I will end, and thank you very much, and terima kasih, and I'm available for any questions that you may have. Over.
Thank you. Thank you so much, Dr. Bati, for inspiring us on the action plan for us, a policymaker, especially for colleagues in the National Health Policy Agency. You're talking about the CVDs, especially on stroke and the risk factor on hypertension and diabetes. It's give us a guidance, direction, how we can do some more improvement on the policy and implementation. We have many questions actually in the chat, but please stay, Ibu, because we are going to listen on one more important speakers. We have Dr. Lin from Vital Strategies. Let me try to brief everyone on his profile. Dr. H2 Kiao Lin served as Senior Technical Advisor for the Asia Pacific region at Vital Strategies. He leads efforts to strengthen population-based cancer registration across the region. A medical doctor by training, Dr. Lin holds a postgraduate degree in health economics, health policy, and healthcare management from the Karolinska Institute in Sweden. His early career with Medicine Sans Frontiers focused on delivering health services to vulnerable and underserved communities, experience that shaped his commitment to equitable health systems. He started as Myanmar's country coordinator for population-based cancer registration in 2018, and he has been a GICR NET trainer accredited by the International Agency for Research on Cancer. He currently supports the Ministry of Health in Cambodia, Sri Lanka, and Vietnam in building sustainable high-quality population-based cancer registries. Dr. Lee, you have the floor. Thank you.
Thank you, Dr. Siri, and thank you, everyone. It's my pleasure and honor to be able to talk during your very historic milestone of setting a very good, I think, in my opinion, will be very potentially very successful stroke registry. And actually, after I listened to Dr. Riza, I think that the Indonesia team is hitting all the points on my presentation. I think my presentation is no longer needed, but anyway, I would like to talk a little bit about my experiences and lessons learned when we were working with like different low and middle income countries and setting up population-based cancer registries. And actually, I bring the experience not from the countries, but also from the International Agency for Research on Cancer, IAC, where they have this kind of monitoring and evaluation framework to make sure that the registries are successful, sustainable, and like meeting their targets and objectives. So I think this is also one thing. So Dr. Sri, and if you don't mind, please next slide. So this is a short presentation. I would like to talk a little bit about our organization, Vital Strategy, just a little bit. And second point is why we focus on cancer and why a population-based cancer registry is so crucial. And that is about the surveillance, where you can see a lot of like similes, like a lot of like takeaways from like the conclusions between the NCDs and from the cancer to stroke, and also for the cancer control. And the next point, I will be talking about steps and challenges. Step and challenges in the planning stage of a cancer registry from the monitor and evaluation framework we developed in the International Agency for Research on Cancer, which is the WHO's official cancer body. And we have some discussions on a case study from Japan, where they have like different fragmented PBCS into a national consolidated one. And a key message slide. Next slide, please. Next slide. So for Vital Strategies, for Asia, we work in Cambodia, Vietnam, and Sri Lanka. We work very closely with IAC's regional hub in the Mumbai city, Tata Cancer Hospital, and we work very closely with National Cancer Center of Japan. And in Africa, we work in 5 countries, mostly on the eastern part of Africa, and we also work with regional bodies in Kenya, Cote d'Ivoire, and South Africa. And actually, this year we are extending to Angola to have a regional IAC collaborating center. Next slide, please. So we work very closely with several registration and vital status partners, data impact partners, global grant partners, International Agency for Research on Cancer, African Cancer Registry Network, Tata Cancer Hospital, National Cancer Center, Japan. And we're also starting to have some discussions with Oslo DHIS team because of the health information systems. We want to have the like connections with the digitalized systems, and we work with different agencies and ministries of health in these countries. Next slide, please. So far, we have some achievements. In for example, like in 5 countries, we have published incidence for cancer survival estimates for the first time ever in their history of the countries. 4 countries, they have strengthened central coordination through strategic plans or national advisory committees. 5 countries, they began their transition to DataS2 or cloud-based reporting systems for improved data quality and timeliness of cancer reporting data. And we also support a lot of small grants through global grants programs such as Angola, Cote d'Ivoire, Paraguay, Sierra Leone, like Guinea, Nigeria. And this year in Asia, we are supporting Bhutan. Next slide, please. And not only at the country level, we also work at the global level. For example, together with IAC, we helped develop the first ever e-learning course, the standardized training module for PBC and low and middle income countries, monitor and evaluation framework for the population-based cancer registry, the DHIS2 add-on module for oncology, COF10 and guidelines for the PBC, how to measure the causes of activities. And also we are supporting IAC regional collaborating centers and centers of excellence. Next slide. So my second point of the presentation is why cancer. Like stroke is very high mortality as like our beloved WHO personnel also told, and also cancer is the second leading cause of death for over people over 15. In 2020 data, cancer caused nearly 10 million deaths, and 70% of these deaths occur in resource-constrained setting. So cancer is important, cancer is fatal. Next slide, please. And when you look at the global map, the population-based cancer registry data availability, especially in the low and middle income country regions, is too low. The blue ones are the countries with like high level of population-based cancer registry data. The yellow one, the orange ones, the black ones are where you really need improvement in terms of data. Next slide, please. So, and when you look at the cancer surveillance framework from the WHO, you see the spectrum of cancer from the healthy population where they first diagnosed with cancer, then there's living with cancer, get treatment with cancer, and dying from cancer, or probably also like cure from cancer. So there are different things you can measure in the different perspectives. For example, healthy population, we measure like risk factors. When cancer is diagnosed, we try to measure the incidence, like how many new cancer cases, what are the prevalence, and how is the survival by each and every cancer type, by age group, by male and female, all these like different variables. And in the dying from cancer, you measure the cancer mortality. So there are different ways of measurement, risk factor and other things we measure with population surveys. For the cancer incidence and survival, population-based cancer registries. Cancer registries are the most important one. You can see they are the critical core component of a cancer surveillance framework. And also for the mortality, you need by the statistics because many patients may die in the hospital, but also many patients may die from at home. And I think for Indonesian team, I think the way you plan is excellent. And if I have a mild suggestion, maybe you can also think about some stroke patients who's like selected to die at home in the hospitals so that you can also have better mortality data in the future. But this is something for your team. Maybe already thought about it or not yet. But anyway, the population-based cancer registries are the core component of the cancer surveillance framework. So you can also have a lot of extended surveillance measures like attributable risk, prevalence, tallies, and associated economic causes. So to actually, like Dr. Riza and WHO lady said, like it's important to be measurable so that you get the measurable outcomes and like all really monitor. And cancer registries are a very core component of a cancer surveillance system. And registries are, I think, core component of any surveillance system in that aspect. Next slide, please. So also, cancer registration is increasing in the global priority. The WHO Global Cancer Monitoring Framework on NCDs have indicator number 2 to measure the cancer incidence by type of cancer per 100,000 population. And World Health Assembly Cancer Resolution, World Health Assembly 70.12, cancer prevention and control in the context of integrated approach. Here, I would like to focus integrated approach. And that includes to collect high-quality population-based incidence and mortality data on cancer for all age groups by cancer type, including measurement of inequalities through population-based cancer registries, household surveys, and other health information systems in order to guide policies and plans. And I emphasize again on the integrated approach because not a single tool, not a single registry or a single survey can contribute all the meaningful, can have the 100% impact on the policies and plans. So these are very important tools by individually, but we also have to have an integrated and a bird-eye view to guide and translate into meaningful policies and plans for the countries. Next slide, please. So here I would like to feel that cancer registry include not only the data production, but also linkage with actual data use in the public health. And I would like to say that this is not only for the cancer registries, whereas you have data collection, data processing, data analysis, data dissemination and communication. But I would like to suggest that you should not stop at this level of producing reports and producing facts and figures. You should also work closely with data use side, where that includes planning using the produced data, implementation, and evaluation using the registry framework you have used in your country. Next. So here is the population cancer registry site, and here is the public health site. So it can be cancer control, or it can be any public health program for the registry. And there are different stakeholders involved in the data production and data use. I saw one question in the Q&A. For the cancer registries, you have to use not only the government hospitals, but also private hospitals, private laboratories, any other source of data. That may not be limited to Ministry of Health. Sometimes you have to use data from Ministry of Interior, or you have to use the data from General Statistical Office, where you try to link with mortality data, so that you have not only the incidence data, but also meaningful death data from cancer, and also so that you can translate into cancer survival data, cancer outcomes data for each and every different cancers for different populations. Next slide, please. So I would like to share some of the thinking in the International Agency for Research on Cancer. I am not going to the details of the tool. So for the cancer registries, we have divided into three main stages. One is the planning stage, where there's like from the day one to like 6 months, 1 year, 2 year, where the operations are planned. And there's the maturity stage, where the registry is functioning, operating. So there are still a lot of improvement, but they are like trying to get mature. And the next stage is the functional stage, where the registry becomes a very high quality, fully functional registry. So there are different focuses and different types of challenges during the stages of the registry. And during my brief presentation here, I would like to bring your attention to the planning stage, because I think this is where the Indonesian colleagues, especially the very respected team in the Ministry of Health in Cambodia, I think they can have like maybe some ideas. So for the IAC, International Agency for Research on Cancer, we have like 4 main categories of focus. The first and the most important is the governance. And the second is the actual operations of like data collection, like communications, data analysis, reporting, all these fall under operations. And that focus is in the personnel, and the fourth is in the infrastructure. Infrastructure may also include like digitalization, digitalized health systems, and all these. So here we have a lot of like questions and issues and the focus in the governance. So I hereby give you a screenshot from the governance questionnaire of the IAC on the monitor and evaluation of cancer registries. So here I would like to share some of the most important part. Usually, we focus mostly on the operation side of things in the cancer registry, because these are day-to-day things. Where there are a lot of challenges, because we are trying to make sure things are running smoothly. But on the other hand, from our experience in the lower middle income countries, governance is the single most important factor in deciding the success and sustainability of registry operations. The registry need to have a very clear mandate by the government or like from the local authorities. They need to have some form of coordination mechanism. For example, here data resource practice is that there is 10 hospitals to be piloted. And there's also a lot of support internally within the ministry, and also a lot of from the external like IHME and other bodies and WHO. So the registries need to have like some kind of the mentoring body. So there should be a strong leadership as well as a strong coordination body where they will solve a lot of like different things. And there should be some form of legal basis. So it can be in the form of laws passed by the national parliaments, national lawmakers, or it can be within the ministry directives, or it can be like local directives from the local government, so that private hospitals and other sources of data are also included. And also to make sure that data confidentiality, data privacy, data security rules are followed, data sharing protocols are in place. And also you should have a step-by-step plan to launch the registry. I think Dr. Rizal's presentation hit a lot of these points. I would just like to focus that governance is often the elephant in the room, whereas everybody kind of see it, know it, but often don't talk about it. We usually talk about operations a lot. So I would focus that governance is the single most indicator of success according to our experiences in the lower middle income countries. Next slide, please. So here I give a little bit more on the indicators about the registry operations, like selecting the target population, like selecting the coverage area, selecting the hospitals, developing the data collection forms, which variables, which type of data are we going to use, like what is the method for data collection, for example, how to collect like electronically or paper, or how to make the data transmission secure, all these things, and ensure access to the vital statistics. So for the Kinsa registry specifically, we need not only the Kinsa numbers, but also the number of Kinsa deaths, and very individually need to be able to trace them back to the individual date of diagnosis. So for Kinsa registry, vital statistics is very important. I think for the stroke patient, most of them may probably die at home. I am not sure about the vision in Indonesia, but I would like to suggest that if you have like stronger vision, it's also good to think about linkage to the mortality system, especially for patients who are dying in the non-hospital settings. And also for the operations, we have to make sure the procedures for record consultation. So it's basically the standard operating procedures. And Dr. Riza also talk about like the registries, the hospital, they have to follow the same forms and guidelines. I think this is fantastic. And also now selecting the registry software system, all these things. So these are some form of the operational things the IAC, WHO can probably look at like at the planning stage of a registry. So I'm not going to dive deeply into personnel infrastructure, because personnel, you know that you have to train people, you have to maintain people, you have to make sure that people are involved. There's always reporting and feedback happening, and also making sure the trainings are well done, and also make sure that the infrastructure needed for operations like IT systems, the office, even like the stationery. If you are trying to follow up patients, how to support the follow up for the staff and for the patients, how to break the news, or like how to communicate. All these things are also very important. So next slide, please. So here I would like to talk a little bit about a case study in Japan. So I have several examples from the actual countries in Asia and Africa, but I think Japan is interesting because what I see from your objectives in Indonesia is you like to do a national level stroke registry. So to be very clear, for the International Agency for Research on Cancer, IAC, we don't usually recommend national cancer registry because these are very enormous stacks of effort and money to run cancer registry across the nation. So what the IAC usually recommend is, they usually recommend a smaller subpopulation level, population-based cancer registry, where you really dive deep and make sure that every cancer is counted in that population, and use very statistical sound method to project the number of incidents and like survival statistics nationally. But so this is what we do in our Asian countries. But in Japan and also in Sri Lanka, they also have the national cancer registries. So national cancer registries are like the aggregates of different population-based cancer registries. In Japan, they have the prefectures. They have like 47 prefectures. And this is the timeline since the actual beginning of cancer registries in the 1960s. where the world famous Professor Dr. Seji. A lot of people from epidemiology probably know that WHO has like WHO standard world population, and before that we have the SAGI population. And in SAGI population is a measure of making sure that countries with very different demographic profiles, countries with very different pyramids of population can have like actual meaningful comparable outcomes. So he was the original developer of the SAGI population used by the WHO. WHO has moved on, but he was the guy that started cancer registries in Japan. And you can see that a lot of like there was some graph of like the number of cancer registries, population-based cancer registries in the prefectures. And in Japan, they have like 3 stages. They can be like divided into 3 stages, where they started registries in the 1960s, and they have like after 15 years, they have like some form of research group organized. Previously, they were individual, and they have like research groups organized. And in the 1983, they are also subsiding for the help from so that the registry can have official money from kind of like government bodies. And in the 1992, Japanese Association of Cancer Registry was like established. So you can see the graph. Once you get money from the WHO body, and also they became more aware that the number of registries are growing steadily, and they have their first Japanese Cancer Association, Cancer Registry Association in the 1992. And then, unfortunately, in the 1998, I think there are a lot of things happened in 1990, like including the world economic, some form of economic crisis, and the subsidy stopped. So you found there's some plateau of the number of registries in the country. And then in the 2023, there's the Protection of the Personal Information Act. There's the talk of like data privacy, individual privacy thing. So registries struggle a little bit. If you are interested, I can talk more about South Korea and other countries as well. And in the 2026, there's a Cancer Control Act. So Cancer Control Act. So there's like more and more laws are coming into data collection about the cancer and cities. And in the 2013, they have a specifically the lawmakers specifically passed a law on the Cancer Registry Promoting Act, because the cancer registries really needed that law because of a lot of like data protection issues. So here the message is cancer registries, or I would say that most form of surveillance systems are routine activities. They are usually not very related to the consent, ethical consent forms or consideration, because they are the part of routine government surveillance forms. So a lot of we get a lot of questions from private hospitals. What happens? Like, are we allowed to share the private personal information of the patients? What about the data confidentiality and privacy? All these things. Very, very good questions. And actually, these are brilliant questions. And for usually for most surveillance systems, you don't need like ethical committee approvals, because they are the government bodies and the data is managed by the government, except in exceptional cases. So you don't really need to worry about it. On the other hand, the registry also need to make sure that enough and adequate and strict adherence to the data protection rules should be followed, at least at the country level laws and regulation. So next slide, please. So you see that the budget for cancer control also improved. So like from the 1950s, and then they get their first funding from the subsidies in terms of like 1983 and 84. And then you see that the budget is increasing, especially after they passed their law, cancer registry promotion law in the 2002, 2003. So you see that this is very important for long-term sustainability and success. So meaning that sometimes you have a very strong leadership in terms of like a clinician or like some high-level people in the Ministry of Health. But once that person leaves, then the registries can sometimes collapse. So it's important to make sure that the sustainability is built into the system in terms of like financing, staffing, and legal status, like data protection and all these things. So that like when a new leadership comes or when the hospital directors change, they question and question about the use and all these things. So I think Indonesia has already made a lot of thought about it. So here in this slide, I would like to show that it's not a immediate success. It's a long-term careful planning. Here you see that they have a 10-year strategy for cancer control in approximately April 1984, from 1984 to like 1994, and they have like next 10 year So the next 10 years, like the consolidation stage. So where they trying to have like new comprehensive strategy to make sure how to like include everybody. Because what happened in Japan was at first every prefecture, every hospital have their own registry, and they collect different types of data because there are a lot of clinical research and everything going on. And nobody, I would say, like most of these people don't want to use the uniform standardized forms and procedure because they have different needs. So they say they have different needs and all these things. So Japan spent a lot of time to make sure that the procedures, the process are standardized and harmonized across all these 47 prefectures and all the different hospitals. So sometimes these professors are very high level. So they say that your questionnaire is not enough. We have our own better version of it. Let us just use our own and all these, which are also kind of true. But on the other hand, at the national level, you really need to use the standardized forms and procedures so that sustainability, their training capacity, all these things are easily transferable and measurable across the registry. So the next 10 years from April 2024, after the Cancer Registry Promotion Act, they have this kind of like moral vision in the Cancer Registry, not only standardizing and consolidation, but also with linkage to like clinical trials and all these uses of the data in the country. So next slide, please. And in terms of the development of the registration from 2004 to 13, they have like 8 objectives. So they have stage 1, set of efforts to standardize and quantitatively improve the accuracy of population-based cancer registry. So it was the stage about 3 years about standardizing and data quality. And the second stage from 2006 to 2009, about like 6 years is promotion of standardization and quality improvement. So it's more like consolidating the standardization efforts and consolidating the data quality improvement. And then that stage was enhancement to meet the objectives of the population-based cancer registry, which are the 8 objectives they mentioned. So the objectives were legislation authority. So they try to make sure that things are legal, standard data collection and content and format, data completeness, timeliness of the report, which is also very important, data quality, and also not only data collecting, but also follow-up survey, which includes matching with the death certificates and resident registry. So they are matching with data from city halls for the death certificates and also regular statistic reports. So this is the monitoring of cancer evidence and data after the law, cancer registry promotion law was passed after 10 years. So they took like 3 years for standardization discussions, next 3 or 6 years for making sure that the standardizations are followed, and the third stage of like 3 or 4 years to make sure that the registry objectives are met, especially in terms of legal status, data quality, follow-ups, and linkages. Next slide, please. So I would like to say that from the low and middle income countries, examples, and also from the Japan, there are a lot of things contributing to challenges and success. And I would like to focus the success because I think Indonesian is built for success. Not only the stroke registry, but also a lot of the health system initiatives and changes the way I see it. So I would like to here give us some takeaway messages for the registry success, which are kind of resonating with a lot of the things that Riza has said. The first is, and the most important, is strong leadership and political commitment. The leadership is the single most important variable we have found in our different countries in Asia and Africa. Without it, things definitely won't work. The second is excellent coordination and communication mechanisms. So this can be between hospitals, between the registry team and other departments of health, between the Ministry of Health and other ministry bodies. And the third is sustainable funding and staffing. Sometimes what happens is donors or WHO or like ministry bring a lot of pocket of money, maybe from the World Bank or some other body, like $1 million, and then things are working. As soon as the funding is stopped, things collapse, like the USAID system. Like they cannot even it's very difficult to even produce the regular indicators since the funding is stopped. So also it's very important of sustainable funding and staffing. You have to make sure that the staff are government staff and they are well trained, they are well maintained, And next S is the standardized procedure. Like everything should be standardized. So if there are other hospitals that want to collect more, of course they can also do. But the registry need to have the standardized procedures and protocol. That definition should be the same. The follow-up and everything should be the same. So that even if one hospital or one region stop functioning, it's easy to transfer and retrain people from or send people from other registry or other places so that it's easy to reestablish in that area or that hospital again. And another is adherence. It's important to strictly adhere to the international best practices. So sometimes what happens in the low and middle income country is a lot of professors and departments have a lot of different interesting ideas they want to test out. So these are good, but on the other hand, at the minimal set, you need to follow the international best practices. You need to follow the indicators. You need to follow the data reporting rules and regulations. So international best practices should be followed. And another thing is I'm echoing is the good monitor and evaluation system with measurable output and outcome. It's not enough to say that we have data from like 10 hospitals or 15 hospitals, or we are covering the 50% of the population. It's important to make sure that the outputs and outcomes expected are measurable so that you have a good M&E system to measure the progress and success. And another thing is contributing to the local, national, and regional health policies and research. It's important not to just produce the number, but also make sure that at the division level, at the prefecture level, at the national level, and also that there is a talk about working with the WHO IHME, which are brilliant. So it's important to have local institutions, university, research institutions, have access to the data you have. So there may be like some form of consent forms or data sharing agreements on all these, but it's important that everybody who is interested should have access to the data. And then there should be some mechanisms built to make sure that the data registry is producing should be used into actual health policies and research. And there should be some form of measurable output and outcome indicator for that. Next slide, please. Thank you so much for your time. It's a very short presentation because I don't want to focus too much on cancer on the stroke day. But any questions are welcome down in the Q&A session, or you can email to me. Thank you so much.
Thank you very much, Dr. Lin, for your presentation. It's a very insightful presentation. You're talking about how you share the best practices of doing the registries. We are now currently doing the stroke registry as well, so it's very aligning to our important action for Indonesia. So I would like, it's very timely because we are having 15 to 20 minutes for question and answer, and we have many questions in the chat. Allow me to invite Dr. Reza, Dr. Bati, and Dr. Lin. If I may read some of the questions from the chat. Number one, what stroke prevention program have been launched? Is there a nationwide nutrition profile or data available to inform stroke prevention program? Anyone from Dr. Bati, Dr. Reza, or Dr. Lim want to start for the question, please?
I'm happy to go, Ibu, if other
Yes,
colleagues
please.
are
Dr. Bati,
still
yes.
considering it. So I come in from the prevention aspect, Ibu, and I think there is fantastic work that is already happening by Ministry of Health, in which we and other UN agencies are very happily supporting. I've already talked about tobacco, and I think what I will do is there are a couple of other questions around lifestyle changes. So if you don't mind, I'm just going to kind of combine them together. For nutrition, we are working at the population level. There is work that's happening around setting up a national sodium benchmark. This is the work WHO is doing with Ministry of Health and with the BPOM. Similarly, we have done some evidence generation around trans fats and levels of trans fats in the most common street food in Indonesia. And we found some in Roti Mariam, for example, some high levels of trans fats. So I think there is work that's happening around there. There is also some amazing work coming out of Ministry of Health on the National Health Promotion Review and the National Health Literacy Survey that is ongoing right now. And I think based on that, there will be some more campaigns in future that would be coming. In terms of what we can do at an individual level to reduce our risk is being mindful. Being mindful of how long you're sitting in one place. Be mindful of where your physical activity is coming in from. I know things are changing. We're spending so much more time on public transport and in the buses and all, but use every opportunity to be more active. Every hour, if you have a desk job, stand up, walk around, because it all counts. Similarly, for tobacco, if you're using, consider cutting down, consider stopping. If you are surrounded, try to think about exposure to secondhand smoke in your home, in your workplaces, and see if you can make your homes smoke-free, and talk to your colleagues if your offices are not, if your workplaces are not. And for diet, again, a diet which is rich in vegetables and fruits. So taking between fruits and vegetables, we are in Indonesia is the country of God. Everything grows so beautifully. We have so much available around us. It doesn't have to be something. Eat seasonal, eat local. Try to get 4 to 5 servings of fruits and or vegetables, and one serving is about a small, what fits in your hand. And potatoes and tubers, they don't count as vegetables, just so that you know. So it needs to have a good balance, and if you can cut down on processed food, anything that you're buying from Kaki Lima, or you're buying from the fast food places. I'm not saying don't, I'm just saying cut down. And I think making those small changes are absolutely important at an individual level. The other measures, we are working at the government, at the population level, to make sure that the environment is healthy. But I think we as individuals, as health professionals, we have 400 people here, we have 60, 70 on YouTube. Think about what one small change you can make. We are all coming to the end of 2025. Everybody's making next year resolution. Don't make something big. 10 minutes of walking every day. One less meal that you eat from outside. One more vegetable serving that you will add to your diet. One more fruit that you will eat. And one more colleague or who might be smoking around you, or a relative or a friend, to tell them to stop, because it impacts not just them, it also impacts you. So, over.
Thank you very much, Dr. Bati, for the healthy promotion. Dr. Reza, you want to add something, or Dr. Lin, please?
Yes, thank you, Dr. Sriwayuni. So the main pillars of stroke prevention are the community screening, early detection, and then based on that screening, controlling the risk factors. And what our government has done with Cek Kesehatan Gratis is really good, really great, because it will capture all of the data in all of our populations, their risk profile for having cerebral vascular disease of a stroke. And we don't yet have a specific national nutrition profile, but based on those data from Cek Kesehatan Gratis, we can explore the data of the obesity and the hypertension, and then the lipid profile. But it is not a specific nutrition profile. But I think we can look at this data and move from there. Because by just controlling the hypertension, we can reduce the risk of having stroke by half, by 50%, 40 until 50%. And that is really great numbers. And the other pillars are the public education and also lifestyle promotion. And what I have seen in other countries, the education for non-communicable diseases and also the lifestyle promotion is also being done at the level of the kids. They educate in the primary school, the secondary school, and also in the universities. Because what happens in stroke, W also has this campaign where they teach young kids what are the symptoms of stroke. Because the one that may recognize the symptoms when the grandparents are having stroke or their parents are having stroke, one of them are the kids, the children. So that is one solution that we can do for the public education and also lifestyle promotion. And the fourth, I think this is also a problem in our country, long-term follow-up and also the secondary prevention. We have to monitor our stroke patients that has been discharged from the hospital and then already in the community, and what's the role of the puskesmas and what's the role of community rehabilitation. And what the ministry is currently doing is developing a pedoman pengendalian stroke dari Kementerian Kesehatan, and hopefully this pedoman, this guideline, will improve our stroke, controlling the stroke in the primary care from the early screening, community screening, early detection, the education, and also the long-term rehabilitation. Terima kasih, Ibu.
Thank you so much, Dr. Reza. Dr. Lin, you have any additional comment?
Yes, I have no specific answer on the prevention things happening in Indonesia, but I would like to say that a lot of the risk factors of the NCDs also share being the risk factors for cancer. For example, like obesity, smoking, air pollution, alcohol, diet. These are proven, well-known risk factors for a lot of different cancers. So I think it's important that whatever gut surveillance system or whatever screening or early detection program happens in the countries, they need to have an integrated approach. Meaning that if you have a blood pressure monitoring program, you should maybe think about also about like teaching self breast examination or vice versa. If you have a breast cancer screening program, you should also take in this into like maybe measuring the blood sugar or like all these things. So this is why we think WHO is also going in that direction. It's integrated approach because these are very related. And the second I would like to say is in terms of the death data. For example, a lot of the patients they say that they die from cardiovascular accident or stroke, but on the other hand, they might have underlying cancer, or also vice versa. They may die from some episodes of cancer with a lot of underlying hypertension, diabetes, and all these things. So I think for the country level and also for the surveillance system level, these kind of like causes and underlying causes of death should also be like able to be shared to between the surveillance systems and registries, and also between the Ministry of Health to other like ministries if there's parallel systems of collection. Thank you.
Thank you, Dr. Lin. So I'm also proud to announce that talking about the Dr. Reza mentioned on the free health checkup program, we currently have 50 million population out of 280 doing the free health checkup program. We are expecting to have more. We have posted the barcode for One Health application where all of the Indonesian people can access their health record. So especially when doing the free health checkup program, everyone can see the health record on the Satu Sehat or One Health application. So please, everyone, do the scan for the barcode. You are going to see a wonderful application and see how to maintain your health. So thank you very much, Dr. Reza, Dr. Lin, and Dr. Bati. I have also to invite one participant from the Zoom, Mr. Mustafa. He's raising hand. I hope he's still with us. Mr. Mustafa, do you have any question to go for the speakers directly? I'll give the speaker to you to talk directly to the panelists, please. Mr. Mustafa, I already opened your mic. You may want to deliver your question directly to the panelists. Maybe if Mr. Mustafa is no longer with us, I'll continue the question from the chat box. Let me try to read one of the important questions for Dr. Lin from Ms. Yusleli. Dear Dr. Lin, in the way of collecting cancer data in Japan, is all of the hospital doing the registry or just a sample? If just a sample, how big is the sample to represent a country? Thank you. Dr. Lin, you have the opportunity to answer the question.
Thank you, Siri. And so for the Japan, you remember the PES and national law. So it's the cancer registry promotion law. So by law, every health clinic, every health facility has to report to the cancer registry. So what happened is they have 47 prefecture, and each prefecture has a population-based cancer registry. All the hospitals and clinics in the prefecture have to report to this one. And the 47 registries, they report to the national body, National Cancer Center Japan. So the database is online. So the reportings are also like in the main server of the NCC Japan. So this is for the Japan, because Japan is a developed country, they are rich, they can do a lot. Usually for the low and middle income countries, developing countries, we don't recommend because it's too costly and too expensive. And Ministries of Health simply doesn't have enough time, manpower to handle this kind of thing. So what usually happen and what IAC recommend is you need to sample a population size. So preferably, we hope that we use that from the capital city or where as place of interest where you have enough cancer diagnostic capacity, because you need to have confirmed cancer diagnosis clinically or radiography or like pathology. So, but you need to have like confirmed cancer cases where you have diagnostic capacity and maybe also some treatment capacity. So we usually start with the capitals of the country or maybe like smaller district. For example, in case of Sri Lanka, we don't collect the data from all the Colombo city or like all the province. We collect from one district. So the same in many countries, you then collect from one city or one district. And then make sure that the population-based cancer registry runs well for like a few years. Then you may think to expand to other countries. For example, in Vietnam, we have one population-based cancer registry in the north, Hanoi City, like 10 million population, and the other in the south, Ho Chi Minh, 10 million. And we are thinking that the country and IAC thinking that maybe we should have some in the middle of the country because it's a long country. So in general, we either aim for like 20 to 30% of the population cover of the whole country to have enough representative sample. On the other hand, if you are smaller communities, for example, there are like different ethnicities or different traditions or culture or diet, you may also think about setting a specific small population-based cancer registry for that area of interest. For example, in some countries, like liver cancer is more prevalent in the coastal region because of the diet of the snails and crabs where they have the liver flakes. So that particular kind of areas you may want to think about. Or if you have like a small remote mountainous area where you still have cancer diagnosis and treatment, that you are interested because of different culture and food and tradition, you may also think about these things. Or in some ethnicity, for example, esophagus cancer is more common in some types of like Indians and like Indian ancestry and this kind of thing. For example, like East Asian, they have more about stomach cancer. So there are also different ethnic compositions concentrated in one particular area. You may also think about this as form of better representation and also for the hair equity aspect. Thank you.
Thank you very much for the explanation, Dr. Lin. We still have 5 minutes, but we have more than 5 questions in the box. But please, Dr. Lubna and Dr. Reza, you have one question from Ms. Nikma. The question is, how are the policy of WHO and the Indonesian government handling the informal caregivers of stroke patients from relatives? Cause many patients who have entered the recovery phase from home care are burdening caregivers, ultimately increasing the number of people at risk of NCDs, especially stroke. Dr. Reza and Dr. Mati, please.
Yes, thank you, Dr. Sri. Please excuse me, Dr. Bati, to answer this first. So my answer might not, how do you say it? Because I'm coming from the hospital background. I'm working in the National Brain Center Hospital. So what I can say is based on my experience as a clinician and also based on the study that I have read about the about stroke. But about the policy making, what are the policies that has been there? Maybe it's better from the Ministry of Health or to answer this. But based on the study, the caregiver of stroke patients also might face the burden of taking care of stroke patients. And this may decrease the capacity of the caregiver to take care of the stroke patients. And the data shows that when the caregiver experience the burden, the stroke patients also having a decreased function at the same time. Decreased function, poor blood pressure control, poor blood glucose control, because the caregiver takes care all of this for the patients. So by identifying which patient with which caregiver will have more burden, then we can incorporate this into the policy, and then we can have also a checkup for them. We can incorporate the cek kesehatan gratis. We have to check as well their condition, not only the blood pressure, the blood glucose, but also the emotional level and also their mental health of the caregiver of the stroke patient itself. So that's the what my point of view as a clinician and based on the study that I've read. Thank you, Dr. Sri.
Thank you so much, Dr. Reza. Dr. Bati, you have the opportunity then.
Thank you, Ibu Vayu. I think it's an absolutely brilliant question because the burden of stroke and then the disability that I talked about in my presentation, it's not just on the patient because of the limited mobility and other recurring impacts. It really does put a lot of burden on the immediate family. And in a system like Indonesia, where we don't have, in some of the European countries, it's part of the national health insurance system and the social protection where people are able to access a nurse or a physiotherapist or somebody who's actually providing home care for rehabilitation. So I think in low middle income countries or even in countries where insurance doesn't cover it, the burden does come to the informal caregivers, which is the family. So definitely, I think this is an area to explore. In terms of looking at potentially some service, not service training really, but some training packages for the cadres who are already providing a lot of community level support. Again, some online tools, some videos. I mean, we are in a TikTok country, right? So having some of those training material distributed as part of at the Puskesmas, as part of the ongoing care and rehab, I know this is an area of work which is still being developed, but I know there's a lot of interest in this from the DG Public Health and other colleagues. So we are keen to also support this going forward. Over.
Thank you so much, Dr. Bati. Last question before we go to the next panel session, which we
Ibu,
already have.
I think there is Dr. Valerie has his hand up. I think he wants to contribute.
I know. I think Dr. Valerie will go to the next panel session, but let me one more chance to give the participants opportunity about the question. This is last question, Ibu Bati and Dr. Reza and Dr. Lin. Last question, how WHO can support capacity building in disease burden estimation and policy translation in Southeast Asia? Also for Dr. Reza, can you explain more about hospital mentorship system? What are the specific efforts to standardize stroke care across all levels of healthcare facilities? I give the opportunity first to Ibu Bati, Dr. Bati, and next to Dr. Reza and Dr. Lin. Please, Ibu.
Thank you, Ibu. I'll come from a very broad brush stroke here. I think there's already a lot of work that's happening across the countries. I know WHO and partners are already supporting, strengthening the civil registration and vital statistics system. I think for every country, I think that's a unique need. But similar to what Dr. Raza was saying, I think with IHME and through webinars like this, we are really identifying the gaps where the studies aren't being done. So I think there is work happening already, but I think at the national level, we need more investment in our CRVS systems, in our health management information system, the facility-based patient program monitoring tools that are already there to be used. And we're rich in health data. We have so many health apps and so many dashboards. So I think the matter is just bringing it all together in a uniform manner through a very mindful exercise. But I'm sure Raza will have, Paraza will also have something to add there. Thank you.
Yes, please, Dr. Reza. Thank you, Dr. Bati.
Yeah, thank you, Dr. Bati. Thank you, Mr. Sheikh. I think Prof. Faizin wants to add about the caregiver. Is it Prof. Faizin?
Yeah.
About the mentorship system from National Brain Center.
But before I explain
across
about before I explain about the mentorship or program pengampuan, maybe we can hear from Prof. Faizin, Dr. Sri.
Sure. Okay.
Yeah.
Sure.
Good morning, colleagues.
Good morning.
Joined the session and heard the commentary from Dr. Bhati about resources available for stroke survivors or patients experience stroke and their caregivers. And I can tell you that there are such resources already available for free, online resources. You'll go to the New Zealand Stroke Education Charitable Trust. Just type in the Google New Zealand Stroke Education Trust, and you will see a range of tutorial videos about self-rehabilitation post-stroke and information for caregivers and so forth. Over 40 video clips available for free. Use it. Thank you.
Thank you, Dr. Valerie, for jumping in and explain about the caregivers on stroke management. So give the opportunity to Dr. Reza, Dr. Lin.
Yes,
for the
thank you.
last.
So what we face with the stroke care in Indonesia, the level of the care is very, very different in each part of the country, especially in the eastern part of the country. The level of care is not what we expect And so first we have to what we do in the stroke transformation program or program pengampuan, Bapak Ibu. First, we set the standard. What is the standard of care in each of the hospital? First, the focus is on the stroke unit, and the second one is they must perform thrombolysis. The third one is thrombectomy, and there are also other treatment or intervention that we require. We put as the standard, such as the coiling, clipping, and then the bypass surgery, craniotomy. But the first one is stroke unit, thrombolysis, and then the thrombectomy, because most of the strokes are ischemic stroke. So if we can increase the capabilities of hospitals to treat ischemic stroke, then hopefully the mortality and morbidity will decrease in Indonesia. And after setting the standard also mentions about the medical devices. What is the standard in district hospital? What are the CT scan? How many slices? And which hospital that must have MRI? Is it a district hospital or provincial hospital? And then also the doctors and also nurses and also the therapists. What are the requirements for the doctors in provincial hospital? In provincial hospital, for example, they must have a neurosurgeon that is capable to do clipping surgery and also the bypass surgery. And then what is the requirement for doctors, nurses, and also therapists in the district hospitals? And after setting the standards, then we work with the Ministry of Health to help the hospitals how to get those medical devices and also get the required doctors and nurses. So we Ministry of Health got a loan from World Bank to fulfill those medical devices, CT scan, MRI, in all of the hospitals in 514 cities and districts in Indonesia. And also those loans is also being used to train the doctors and also the nurses. Especially for doctors, we also have LPDP scholarship for fellowship. And then we are still in the process of making sure that the standard in all of the hospitals are the same. We share the standard of procedures. We share the clinical pathway. Then we have to set the KPI. What are the key performance indicators that must be fulfilled in each of these hospitals? And then the KPIs are the thrombolysis, the door to CT scan, door to needle, and then the length of stay of the stroke patients and also the mortality rate. And then after that, the most important part is the monitoring itself, monitoring by having the stroke registry. Because we as the national coordinator for stroke, national brand setter, we still don't know which hospital performs the best and which hospital current data atau data yang saat ini Bapak Ibu, we don't know which hospital that performs best and which hospital that performs worse, and we can approach those hospitals then intervene these hospitals accordingly. Thank you, Ibu.
Thank you very much, Dr. Reza, for the explanation. So last statement from Dr. Lim, I give the opportunity for closing this panel session one. Dr. Lim, please.
Oh, sorry. I was just typing in the Q&A answers. For WHO, I think they already do support in the country's 5-year work plan. So I think for the Southeast Asian region, I'm not sure about the original question, but we have like CIRO and WPRO. So I think these both sessions of WHO for the Southeast Asian countries can better guide and make sure that the countries are putting more resources, more measurements, and like more accountability mechanisms in terms of the 5-year NCD control, cancer control programs and policy, and make sure that the midterm reviews are like meeting the standard. I think this is one way of the WHO doing it. And the other issue is WHO can also link the country governments and MOH to different bodies, because WHO may not have a lot of the money, but they do actually have a lot of like networks and accountability mechanisms. So I think this is where they can be more supportive in terms of capacity building, maintenance, and translation of the policies in making sure that the countries are getting networks to all these like expert bodies for NCDs, CANSAS, and all these things. I would say the most priority is the countries aware about their capacity needs, make sure that they put into writing in their 5-year policies, either national or look at 5-year strategies, and make sure that they are held accountable for it in terms of midterm reviews and like costing mechanisms and like how much resources they are putting into it. This is one way for the WHO. Thank you.
Thank you very much. Very insightful closing statement, Dr. Lin. So as this is 11 past 10, I'm sure next session will be more important. So I would like to end this session by saying thank you very much, Dr. Bati, Dr. Reza, and Dr. Lin, for your insightful presentation and also giving us direction and guidance towards our policy improvement on the registry as well as the stroke care management. For me, as personally, I'm in the National Health Policy Agency, also have so many insights, so many knowledge. I would like to implement the knowledge, and for anyone else from the participant, I'm sure they will also think that we would like to have you in the next webinar for our improvement and our capacity building. Thank you very much for joining us in this webinar. Thank you. I hope you have a wonderful day. Thank you.
Thank you.
Thank you.
Now I would
That's all.
like to invite
Thank you,
Ibu
Prof.
Hardini
Thank you.
for leading us on the next panel session of panel 2. Ibu Hardini, you have the floor.
Thank you, Dr. Sri. Hello, everyone. We meet again. Welcome to panel session 2 of the international webinar on burden of disease data to inform policy decision, a case of stroke burden. My name is Hardini Kusumadewi, and it is my great pleasure to serve as your moderator for this session. In this panel, we will explore how stroke burden data can be transformed into tangible actions, and how international collaborations such as through the WSO and IHME can support evidence-based policies for national and regional planning. We are honored to have with us 3 distinguished experts who have been at the forefront of global research and policy initiatives related to stroke and non-communicable diseases. Our first speaker is Professor Valerie Feigin, Director of the National Institute for Stroke and Applied Neurosciences at Auckland University of Technology, New Zealand. Good evening, Professor Feigin. I think it's about 5 p.m. in New Zealand now. Thank you Thank you for taking the time to be with us today. We truly appreciate your presence and the opportunity to learn from your experience. So, ladies and gentlemen, Professor Feigin is a world-leading epidemiologist who has contributed significantly to the global burden of disease study and stroke prevention strategies worldwide. His groundbreaking work has shaped global health policies on stroke and brain health, including the innovations like the Stroke Riskometer app, which is now used in over 70 countries to help people prevent stroke. He will share insights on the tangible actions to reduce stroke burden. So without further ado, Professor Feigin, please, the screen is yours.
Thank you. I will share the screen first. Okay. All right. Can you see
Yes.
the slides?
Perfect, Professor.
Great. First of all, before I start my presentation, I would like to thank you for your kind invitation to give this presentation. And this presentation is given on behalf of the World Stroke Organization, a Lancet Neurology Commission on Stroke, Global Burden of Disease, Stroke Panel, experts, our National Institute for Stroke and Applied Neurosciences, Auckland University of Technology, and the company called, for some reason, slides are moving by themselves. I didn't move them, they started moving. Okay, good. Prevents MD company, who owns the copyright for digital tools I will be talking about. So I would like to start with outlining the burden of stroke on the global scale. And as you know, the number of people who died or remained disabled from stroke globally continuously increasing from 1990 till now and projected to be increased up to 2050. And not surprisingly, the cost of stroke on the global scale is also projected to increase from just under $1 trillion in 2017 to $1.6 trillion by 2050. And the bulk of the burden of stroke, as you can see on this slide, resides with low and middle income countries, almost 90%. And what are the implications of these findings? Obviously, the current trend in stroke burden continues to increase, and therefore more taxpayers' money would need to be spent on stroke care if the current trend continues as it is. Obviously, urgent actions are needed to reduce stroke burden because that hugely increasing cost of stroke puts at risk the whole health system of the country and globally. And we need to do something to change the situation. We also know that the lifetime risk of stroke is being increased dramatically over the last 20 years. And in Indonesia, for example, 1 in 5 people will have a stroke over the lifetime, which is a 23% increase over the last 20 years, unless effective preventative strategies are implemented. And secondly, stroke is no more a disease of the elderly. Globally, 63% of strokes already happening in people younger than 70 years old. In Indonesia, specifically, look at this figure, most recent, it is 66%, even higher than globally. And there is 100% increase in the number of people affected by stroke before the age of 70 in Indonesia since 1990. So it's a huge increase in the burden. And what are the implications of that? Even now, and we recently published in Neuroepidemiology a paper that many doctors call stroke a CVA, cerebrovascular accident, which is completely wrong. It should be called a stroke, not CVA, because stroke happens to people who have some risk factors. And therefore, it is highly preventable disease. Over 80% of stroke, theoretically at least, are preventable. And secondly, stroke risk increased dramatically, as I said, and therefore we urgently need to improve and intensify prevention at all levels. And I will talk about that in a minute. as stroke is the disease of working age population, we need to switch our preventative actions back to young people. Basically, prevention should start from birth or even early at conception, from the health of mother and parents basically, and then continue over the lifetime of the individual. And that's one of the findings we found in the global burden of disease study I just referred to, that the lifetime risk of stroke is actually does not change statistically significantly from the age of 25 to the age of 75. And therefore, intensity of stroke preventative interventions should not be diminished with age, which we often observe in clinical practice. People say, oh, you are aging, it's a natural process, we cannot do much about prevention, you are aged too much or something like that. At least to the age of 75, intensity of prevention should not be diminished. And the fact of the increased risk of stroke in young people was very nicely recently illustrated by delicately done meta-analysis by Oxford Stroke Unit that showed that the risk of stroke in people younger than 55 years has been consistently increased since 2005 till now, as opposed to decrease in stroke incidence in people older than 55 years. And similar trends observed in Indonesia. And I look at the most recent GBD 2023 data, and there was an increase in stroke incidence in Indonesia in people younger than 70 years, 32% over the last almost 30 years, but decrease in people older than 70 years. To illustrate again the huge problem of stroke, burden of stroke, I would like to show you and remind you that over 12 million people suffer from new strokes every year. In Indonesia, its figure is also quite impressive. 664,000 people, according to the latest GBD data. It is a 114% increase against 1990, huge increase in the number of people affected by stroke. And the number of people who affected and survived stroke and remain with stroke aftermath has also doubled over the last 30 years. In Indonesia, even more than doubled over the last 30 years. As you can see, almost 5 million people live with stroke aftermath in Indonesia. And because the number of stroke has doubled, and in Indonesia more than doubled, more acute and rehabilitation care facilities and workforce are urgently required to match that increase. And all this epidemiological data about the trend and the effect of stroke on the individuals shows quite clearly the lack of efficiency of the currently used preventative strategies, and I will talk about it in a minute. One of the underlying causes of the increased burden of stroke is the increase in the exposure to most important risk factors, such as high systolic blood pressure explains almost 60% of the stroke burden. And other risk factors, apart from the high blood pressure, excessive body weight, high ambient temperature, high fasting plasma glucose, poor diet, low physical activity, all on the rise since 1990. And on the map shown on this slide, unfortunately, you can see that stroke incidence, stroke attributable to high systolic blood pressure in Indonesia is one of the highest in the world. Obviously, much needs to be done to control blood pressure in Indonesia. When I look at the leading 10 risk factors for stroke-related DALYs or disability-adjusted life years lost in Indonesia, I found those 10 shown on the graph, but 5 are clearly the risk factors that should be given priority in terms of the control: high systolic blood pressure, dietary risk, air pollution, particularly household air pollution, smoking, and kidney dysfunction. So how to stop stroke? The only way to reduce stroke burden is primary prevention. Only this way we can reduce incidence. Treatment, recanalization therapies, all of this is very nice, but it's something to improve outcomes of stroke. To reduce stroke burden, actually reduce stroke incidence, only primary prevention is the solution. However, in the recent Secretary General of the United Nations report, he stated that international community has failed to translate the goals of prevention into reality, and that refers to non-communicable diseases first of all. So what are the available preventative strategies we have in place right now? One, which is unquestionably the most effective, cost-effective, and medically effective, is population-wide strategy, when the intervention like smoking cessation or reducing salt intake and so forth applies across the population regardless of the level of risk, with the emphasis on behavioral risk factors. However, there are still no country in the world where such strategy is implemented in full on the national level. And the most important reason or obstacle for that is that these strategies have to be implemented require legislative changes, but there are huge opposition now from industry, particularly pharmacological industry, food industry, opposing those changes. It's very expensive to implement such changes like reduce poverty, for example. It is extremely expensive and requires, changes at the grassroots level of the, people wealth, well-being, and everything. So it's very challenging strategy to implement in full. On the other hand, on the individual level, the most kind of popular preventative strategy is the high cardiovascular risk strategy, which is actually focused on determining people who are at high risk of cardiovascular disease. And once this risk threshold is met, the people who are at high cardiovascular risk are eligible for pharmacological blood pressure lowering and lipid lowering therapy. That's the main purpose of that treatment. However, this strategy miss out almost 80%, some people say 90% of the population who are at low to moderate risk of cardiovascular disease. They are out of the primary prevention because of that high risk strategy by definition. and the very high focus on treatment, medicalization, as opposed to lifestyle factors. And people who are given kind of results of that screening for cardiovascular risk as low or moderate, they received a false reassurance that they are safe from having a cardiovascular. This is a very dangerous issue, actually, given a false reassurance of protection from cardiovascular disease. In health, it's one of the worst things that could happen. So what are the barriers to effective stroke prevention? First of all, most people, I would say, are not motivated enough to improve their lifestyle, to follow a doctor's recommendations, to take medications consistently, and so forth. So lack of motivation. Still, majority of people are not aware enough about a risk of stroke, of having a stroke, and what stroke is, how to avoid it, what are the risk factors. Low awareness of the population. Even in high-level developed countries like United States, Canada, UK, Australia, New Zealand, 80% of people have no idea about stroke and stroke risk factors and their own risk of having a stroke. It also quite costs to people to have prevention, to visit doctors, to have lab tests to determine their risk. Therefore, it is also obstacle to the preventive interventions. Doctors have busy times all the time across the world, have no enough time for effective primary prevention in their routine practice. And one of the reasons for that, they don't have evidence-based digital tools to support their preventative work without actually taking much time of their main treatment work for the patients. And of course, policy inertia and resistance from the government, as I said, a huge industry lobby, pharmaceutical lobby, particularly nutritional industry, to implement preventative strategies on the population level. Just as one simple example of the use of high cardiovascular risk strategy. Let's assume that we have a man of 40 years old who smokes and has hypertension, 140/90, blood pressure. He obviously at risk of having cardiovascular disease. But if we calculate his 5-year absolute risk of cardiovascular disease using, for example, PREDICT or algorithm commonly used for that, his risk is very low, 5-year risk, 1.6%. And if he is told that his risk is low, he probably could start thinking, oh, I don't need to exercise. I can have junk food or whatever silly things in my lifestyle, because he is falsely reassured he is protected because his risk is low. But if you calculate his relative risk of having just stroke, not the overall cardiovascular disease, including stroke, but just stroke, we will find out that his risk is more than 2 times of someone of his age, sex, ethnicity, but without any additional risk factor. And that's something that would make that individual think, oh, my risk is higher than my peer. Why? And what I can do to reduce the risk. That's the first thing to motivate the person to do something about his health. Most importantly, there is a quite convincing evidence from the Cochrane systematic review that showed that high cardiovascular risk prevention screening and strategies are not actually working. It basically, it's even harmful to use that strategy because in the study in Australia, for example, replicated in UK, it was shown that almost 40% of individuals with hypertension did not receive antihypertensive treatment for one simple reason. They are not meeting the treatment threshold of the high cardiovascular risk. Therefore, large number of people did not receive adequate cardiovascular disease prevention. Even worse is with lipid-lowering treatment. Only 4% of people in Europe receive hyperlipidemia treatment because they do not, majority of them, 96%, do not meet the treatment threshold defined by the high cardiovascular risk strategy. As I already mentioned, only minority of people are actually eligible and for the pharmacological treatment of high blood pressure or dyslipidemia. And some experts compare high cardiovascular risk strategy with a naked emperor because it actually does nothing to people, as shown in the randomized controlled trials. And it's also extremely expensive. To prevent one death requires almost a million pounds. It could hardly be called cost-effective strategy. And the most recent World Health Organization expert meta-analysis showed meta-analysis that based on high quality 14 randomized controlled trials, that cardiovascular risk screening had no impact whatsoever on lowering cardiovascular disease morbidity and mortality in the general population. And experts, WHO experts, recommend that countries that have introduced such screening programs should reconsider their efforts. This is a quote from their meta-analysis. This is a very strong statement, which we really rarely see in meta-analysis. Very conclusive and definitive statement. So what prevents us achieving the shift in reducing the stroke burden? Why the focus is on high cardiovascular risk strategy as opposed to the population-wide strategy? And it was shown about 20 years ago, but very prominent epidemiologist, Professor Capewell from UK, that the greatest harm arising from high-risk strategy is misleading professionals, and I would add, and individuals, but planners and politicians into thinking they can tick the mission accomplished box for prevention. That's what happens in practice. High cardiovascular risk individuals identified, screening done, prevention accomplished. And that was a reason why policymakers, Minister of Health, actually like that strategy, because it's easy to report that something is done, but in fact, it is a naked emperor strategy. There is nothing happening on the population level as the result of that strategy, not positive at least. So how
Professor,
to...
pardon
Yes?
me, kindly reminder, you have 5 more minutes, please.
Oh,
5 more
right.
minutes. Okay, thank you, Professor.
Okay. I will skip those trials and just show the evidence for the digital tools that our university has developed and implemented in several countries. One of them you already mentioned, Stroke Riskometer app. These are the screenshots of that app, which is for the lay people, and PreventMD software is designed for health professionals, which is based on the Stroke Riskometer, and it gives results, presents health score overall, showing the importance of even minor changes in the lifestyle, how big effect on the overall health risk it has. All the results are presented in graphs, not only stroke, but also in terms of the risk of dementia, diabetes, myocardial infarction, deep vein thrombosis, a range of non-communicable disorders. And all of this includes tools for motivation of the individual. And most importantly, not most, but very importantly, you can assess real-time assess the effectiveness of the preventative strategies at any level you like. Doctors, individual doctors, GP practices, regions, or the whole country. I would skip the video to show the PreventMD. Just emphasize it was very well validated across a number of countries, and I think my Indonesia experts were involved in that. Not unfortunately not, but some Asian countries, as you can see on the map, were involved in that validation. And most importantly, that's what I would like to emphasize. The digital tools we are currently recommended that Stroke Riskometer prevents have been tested and proven effective in a number of completed trials, and there are several ongoing trials in the world in several countries to prove the efficacy of these tools. The most important and definitive trial in Brazil showed a statistically significant reduction of the blood pressure, improvement of stroke knowledge in Australia and New Zealand trial, and in the trial in Nigeria, there was a clear effect of the stroke riskometer on reducing stroke risk overall. So that's what is recommended by the World Stroke Organization. Emphasis should be on the population-wide strategies shown on this slide and mass individual motivational strategies based on the Stroke Riskometer app and PreventMD software, facilitated by Polypill and shift of work from doctors to nurses or health educators or community health workers, because they can do preventative intervention very successfully. There is good evidence for that from India and other developing countries that it is actually effective. And what I just described to you has received a global recognition. There's a number of national and international awards, including World Health Organization award a couple years ago. And that is what could be achieved with this strategy. 50% stroke incidence reduction. So for Indonesia, for example, where the cost of stroke is over 2 trillion rupiah, this strategy, if implemented widely on the national scale, would save 1 trillion rupiah annually. This is a huge effect, and I can tell you a good news that we now have already implementing these tools in several Asian countries, including India, China, Thailand, Philippines, of course, New Zealand, and we are ready to implement it in Indonesia. It's all available. Just express your interest. I will organize a teleconference and we can proceed with the implementation relatively quickly and non-expensive, really. Finally, I would like to thank my team at the PreventMD company who is behind the digital tool development, and thank you for your attention.
It's very interesting. Thank you very much, Professor Paigin, for those valuable insights and evidence-based recommendations to reduce the stroke burden. Professor, please stay with us because after the three expert presentation, we will have a session of Q&A.
Okay.
Thank you, Professor. Ladies and gentlemen, now moving to our second speaker, Professor Jayaraj Pandian, President of the World Stroke Organization. Hello, Professor Pandian.
Hello.
A very good morning to you. I believe it's around 5:30 in Tunis, right?
Yeah, 5:30. Yeah.
Thank you so much for joining us so early today. We truly appreciate your dedication and presence. Ladies and gentlemen, Professor Jayaraj Pandian is a professor and head of neurology and the principal of Christian Medical College from Ludhiana, India. He currently serves as the president of the World Stroke Organization, the first Asian to hold this prestigious position. Professor Pandian has made remarkable contributions to advancing stroke care and research globally, particularly in improving stroke services and outcomes in low and middle income countries. Today, he will speak about the role of World Stroke Organization and international collaboration in using GBD for policy. Professor Pandian, the screen is yours. You have 15 minutes, please.
Yeah, thank you very much, Anna. I'll just share my screen. Okay, so in the next 15 minutes, I will give you some of the important activities that WSO is doing in terms of implementing stroke care and also at all levels of stroke continuum of care, and also some of the international collaboration that we are undertaking to reduce the global burden of stroke. So I'll quickly go through this slide. Mission is to reduce the global burden of stroke through prevention, treatment, and continuity of care. I think Dr. Fagan would have talked about this pragmatic solutions, how to reduce the global burden of stroke. That's a WSO and Lancet Neurology Commission initiative, which was published few years ago. And we have 4 pillars, and I'm going to talk about the activities in these 4 pillars, how WSO is implementing from acute care, surveillance, prevention, and rehabilitation, not only as WSO, but also as a collaborative effort. So in terms of acute care, there are several models of stroke care that are available. We know there is a shortage of neurologists and even skills in many countries. And in a situation like this, how can we implement stroke care? And this is the alternative model of stroke care. There are several models which are all tested scientifically. The hub and spoke model, task sharing, that is community health workers identifying stroke patients in the villages and referring to the stroke-ready hospitals, and multidisciplinary care, that is typically an advanced stroke center and a specialist-led care as a neurologist who is interested in to deliver the stroke care besides all his other responsibilities. And physician-led care when there are no neurologists in the region, how we can train the physician and how we can implement. So non-specialist stroke care, we tested this in Tezpur in northeast part of India, where there's no neurologist even now. And before and after implementation, we collected data, the key performance indicators, and it improved several key performance indicators, reduced complications, and reduced length of hospital stay. And from there, one of our future leaders from WSO, Dr. Ivy Sebastian, and she developed an app where both training and knowledge, attitude, and practice could be captured. And before the implementation of stroke unit care, KPIs were captured, and then after training and implementation of stroke unit care, again same information was captured. So in 3 countries, India, Armenia, and Malaysia. And this is what they were able to show, that the knowledge, attitude, and practice improved, and there was retention of whatever they learned. There was reduction in length of hospital stay. The swallowing, several key performance indicators improved following implementation of stroke care. So again, a model cross-country collaboration through WSO funding, we are able to establish is that a non-specialist can run the program. So hub and spoke model, there are several models in different countries. The one we recently upgraded this particular program in our own state, where we signed an MOU with the government of Punjab, and we deployed a AI software by which we could quickly see the scans in the spoke hospitals. The spoke hospitals are 3 district hospitals, and CMC Ludhiana is a hub hospital. And we were able to successfully roll out this program in May this year. And thrombectomy patients, eligible patients, are being identified early, and they are referred to us by the integrated pathway that we have. And tele-stroke and telemedicine is very important, and in many of the resource-limited settings, we could incorporate this tele-stroke, and remotely we could implement stroke care. This is a position paper published from the World Stroke Organization, the Future Leaders, the second cohort, and they address this important aspect in this paper. Task shifting models, again, Dr. Fagan had mentioned about task shifting in prevention, and even in early identification of stroke patient in the villages can be done through task shifting, in addition to prevention as well. Nepal, this is another collaborative effort of WSO, World Health Organization, CRO, Nepal Stroke Association, and University of Heidelberg. Together, we are able to develop this stroke project in Nepal, capacity building training, and also research capacity building. The training is being held in the first week of December. So this is another collaborative effort of multiple stakeholders to improve the stroke care in Nepal. Sub-Saharan Africa, this is one of our future leaders from Tanzania. She implemented this stroke unit care along with the government in Tanzania. So we have several examples of implementing stroke care, and the acute care pillar, which I mentioned, in a resource-limited setting. Second is advocacy. It is very, very important. I am extremely glad that this particular program has been organized under the support of the Ministry of Health of Indonesia. We need to have governments on board in order to implement stroke care, implement prevention, primary prevention for stroke. So these are some of the advocacy activities that WSO has done at global level, regional level, at national level, and I will elaborate on the recent advocacy activity. The Advancing Policy Action on Stroke. It's a Global Stroke Action Coalition. It's a coalition of civil society organizations. We have ESO, we have ASA, AHA, Stroke Association of UK, and we have industry partners. And our vision is to reduce the impact of stroke for everyone, everywhere, through bold and urgent action. So these are the 5 R's that we have submitted to the in the UN General Assembly, and also the World Health Assembly. Make stroke a priority, in NCD health strategies. Develop National Stroke Action Plan. Commit funding for stroke, implements robust stroke monitoring systems, includes stroke survivors and caregivers in policy development. So these are the 5 urgent actions, and we have been promoting this in the last 1 year. In the World Health Assembly, we had a side event, and in the recently concluded UNGA meeting, we had a side event, and we had the opportunity to make statement. And so this is a new advocacy program that we have launched the last 1 year, and we are carrying it forward for the next year as well. And this is the UNGA side event that was held in New York recently. 55 participants, 7 ministries, from Argentina, Dominican Republic, Egypt, Fiji, Indonesia, and we had representation, Saudi Arabia and Somalia. So we encourage all of you to join the call for Stroke Action Now. And there are some new initiatives, a global initiative. This is called Thrive Project, a global WHO initiative, where we have divided the regions into clusters, cluster 1, 2, and 3, and focused on these countries. And we are waiting for a major breakthrough for funding. And why this project was developed, because many countries have approached WHO to help them in different areas in stroke care policies and advocacy. So these are the countries currently we are working with at the WHO level and also at the ministry level. In fact, I am in Tunisia for this purpose. They had invited us, and I have a meeting with the health minister. And also today I'm going to see a few hospitals for WHO Stroke Center certification. So WHO Global Stroke Stroke Alliance is basically a stakeholders meeting, policymakers meeting. This was started by our former president, Dr. Martins in South America, and we had a meeting in Delhi, inviting all the Southeast Asian region countries, and Istanbul for the Middle East and North Africa and Central Asian countries. The latest one was held in Hanoi for the Western Pacific Regional Office under the support of the government of Vietnam. And we can see here the minister, the deputy health minister of Vietnam. And there were 240 participants. They were from WHO, they were from the health ministries, key opinion leaders from these 17 countries out of 33 Western Pacific region countries. And we developed an action plan for each of these 17 countries, and it will be implemented over the next 3 years. Stroke quality is again an important area. WHO Stroke Center certification, which was launched as a pilot program in LATAM, and we have upgraded this program. This is a new website, and recently, several countries who had applied. The first hospital we have certified, one from Vietnam, one from China, Nepal, and South Africa. And currently there are more than 130 centers certified across 19 countries. And this is a major program. In Indonesia, the pilot program, one center was certified, but I think we are very keen to roll out this program in Indonesia. So why WHO certification is unique? Because it's global. The stroke roadmap of WHO has been incorporated into this for all levels of healthcare system, data integration, and there is a site assessment by the assessor, and the transparent review process. And it is not that you certify the center and then that's the end of it, but a continuous quality monitoring is needed. Every 6 months, they need to upload the quality data, and a streamlined digital platform as compared to the pilot program. I'll just quickly conclude with few initiatives. Recent one, that is with Egypt, the government of Egypt. We have signed a MOU, the Authority for Healthcare Accreditation of Regulation for Hospitals, to roll up the stroke center certification in Egypt, and we are just waiting for the final meeting to start the program. The collaboration I mentioned, so WHO works very closely with WHO, and this is an initiative from WHO CRO through our collaborating center for WHO in 6 countries. We have worked individually based on the needs that they had, including Indonesia before Indonesia was shifted to the Wipro region. So this is Bhutan. Currently, there are 3 stroke units. When we started the program in 2020, there were no stroke units. And Maldives, now there are 2 stroke units and 1 center has started intervention. And in this WHO CRO program, the WHO country offices involved, the ministries involved, and the hospital and the professionals are involved. Timor-Leste, in the month of December last year, I conducted a 4-day training program. The Union Health, the country health minister, the director of the main hospital, the WHO country offices involved. Now they have started the stroke unit and they have made the thrombolytic agent available. They are going to release the national stroke guidelines. And a similar initiative with the Western Pacific region through from the Manila head office. And we are going to have a meeting for the Pacific Islands next year. This is another opportunity that I had in Iraq, where I was able to meet the country office, and we are developing a Iraq stroke network. And soon, at least, the first hospital will be certified from Iraq. And recently, there was there were 3 webinars we organized with WHO. This is the framework for management of acute coronary syndrome and stroke care. This was for the policymakers. And several of the countries have participated. And the CRO regional meeting, I was able to make statement and interact with several of the CRO policymakers. And just last week, there was a meeting in India looking at the prevention, as Professor Fagan mentioned, how at primary care level we could incorporate the NCD strategies and reduce the stroke burden. So WHO's policy on stroke prevention, I'm not going to touch upon because already Dr. Fagan had mentioned. And these are some of the strategies like Polypill, which he had mentioned, task shifting, and the PROMOTE trial of Brazil. He already showed the results. I'm not going to discuss this. The using stroke riskometer in people with low to moderate risk, and this is the program that was implemented in Brazil. And these are the results. There is at 9 months there is a significant decrease in systolic blood pressure through this program. So surveillance, currently we are working with WHO CRO to come up with a manual for countries to start registries. This should be finalized in a month's time. And then we work with Rescue Quality Registry, SITS Registry, and help countries to develop national stroke registries. So rehabilitation, this is a new initiative, the pilot initiative of rehab center certification. 15 centers have been assessed, and we are going to modify the assessment criteria and roll out this program globally. So, these are the several initiatives from WHO looking at the 4 pillars: acute pillar, surveillance, prevention, and rehabilitation, and also the advocacy in many of the regions. And in a collaborative way, we have launched. Thank you very much.
Thank you very much, Professor Pandian, for highlighting how global partnerships can accelerate data-driven actions and capacity building in stroke prevention and care. Please do stay with us, Professor. We will start our Q&A session after this guest speaker. Ladies and gentlemen, now our final speaker is Professor Robert Aldrich. Hello, Professor. Good evening.
Hi. Good evening.
I know it must be very late hour in Seattle. It's around 9 p.m. But thank you very much for joining us at this late hour. I really appreciate, Professor.
Of course.
So, ladies and gentlemen, Ladies and gentlemen, Robert Aldrich is a professor in the Department of Health Metrics Sciences and team lead for clinical informatics at the Institute for Health Metrics and Evaluation, IHME. His work focuses on using data science to improve public health and make invisible populations visible, including those experiencing homelessness, migration, and other vulnerabilities. So, Professor Aldrich, you have 15 minutes. Please go ahead.
Okay, thank you very much for the talk. I appreciate it. The reason I am late, I was meeting with collaborators from France talking about something very similar. So it's a pleasure to come and talk to you today and this evening about this. I'm going to talk about the use of our tool called the GBD Compare for your stroke planning at the national and regional level. So I'm going to introduce what is GBD Compare. I'm going to give some introduction to how you can navigate GBD Compare and some of the results around that. So what is GBD Compare? GBD Compare is an interactive online data visualization tool. You can use it to explore health trends and patterns and all of the fantastic data that we produce within the GBD study. It's a really, really useful tool that is an interactive system that you can explore stroke and all of the other conditions and causes that we have. So you can use it to analyze disease patterns and how they've changed over time. You can use it to look at how stroke is estimated by age and sex. You can use it to compare countries, so look at Indonesia compared to other regional countries, but we can also look at the data within Indonesia at the subnational level, and we can explore regional trends and global over time. So I think many people may have hopefully been using GBD Compare in the past, but I thought I would give an introduction because it's a complicated tool that has a lot of data. Sorry, it's a simple tool, but it's a complicated set of data behind it. And so it needs a little bit of an introduction. So you can Google GBD Compare, but here is the website link. And I'm sure the colleagues on the call can share this link to everyone. You now have to, GBD Compare was previously available without registering, but now as of GBD 2023, which was released 2 weeks ago, you need to sign up and create a username and a password. But once you do that, you get full access to the GBD Compare. And the most important thing is to answer and think about what questions you want answered using GBD Compare. And once you've started to think about how you want to make your planning decisions for stroke, this is how you can navigate the tool. So this is what it looks like. On the left-hand side, you have the control panel, and in that you can manage the different settings and different chart settings that you're able to choose that have both the different types of and styles of chart that you want, but also the different age groups, sex. And let's just dig into that a little bit more. So there's also a basic and advanced settings that you can choose. The advanced setting allows you to look at more detailed ages. It allows you to choose age standardization or all age estimates. The basic settings are really helpful for kind of getting a quick overview and offering a selection of tools and measures to think about. We have many measures that we produce within the Global Burden of Disease, and within the GBD Compare tool, you can look at all of those different measures. So when you're looking at stroke, you can look at years of life lost due to stroke. You can look at years lived with disability. You can use our kind of keystone metric of DALY's, disability adjusted life years. But you can also look at our estimates of incidence and prevalence over time, the death rates that we estimate, a probability of death, and then not cause specific. So life expectancy is general all cause, and healthy life expectancy is general all cause. But so the other measures have stroke specific estimates, but these ones do not. They're all cause estimates, but they're still very useful. As I mentioned, you can get many different age group and age group aggregations. So all ages and age standardized. And then if you're looking and interested in a particular age group, you can zoom in on that. For stroke within the GBD hierarchy is a level 3. So to get to the data for stroke within the GBD, you need to choose the level 3. But then we also break down stroke into a series of 3 different groups underneath that. So you can choose level 4 to look at more detailed causes of stroke, which I'll show you in a second. You can also explore health from different causes or risk factors. So the advanced settings feature allows you to look at the different underlying risk factors as a result of that are related to stroke. And to get there, the easiest way to do that is to choose the advanced settings and then go to risks. And then on the left-hand side, there's a range of different charts that you can produce. So starting with maps at the top, if you wanted to look at a map of Indonesia or a subnational for Indonesia, you choose that chop chart. And then there's tree maps. And then there's a variety of different other charts that you can choose within the GBD Compare tool on that left-hand side. Okay, so hopefully that gives you all an introduction to the GBD Compare tool. I'd urge you to log in, create a username, create a password, log in and have a look around. And the best way to get to know GBD Compare is to just do that and to get playing with the data because it's a fantastic resource. But let me give you, I think we were here to talk about stroke, so let me give you some results that I think you might find useful and are available for Indonesia within GBD Compare. So I'm going to answer a few questions within the GBD Compare. They're relatively straightforward, simple questions, but I think they'll give you a sense of how you can use it. So we can answer using GBD Compare, where does stroke rank as the leading cause of health loss in Indonesia? We can ask the question of how does the burden of stroke differ across locations in Indonesia? How does it vary by age and sex, and how has that changed over time? And we can also look at what are the leading risk factors for stroke as causes of health loss in Indonesia. So that is all available within GBD Compare. So how do we do that? So one way to look at how big of a cause stroke is, here on the screen here, we have what is called a tree map. So the tree map takes all causes of burden within Indonesia. And here on this plot in particular, I've chosen measures. I'm not sure if my mouse will come. Can you see my mouse on the screen? Maybe I need to change. I think if I choose point.
It's still tree map, Professor.
Yeah. Oh, yeah, it's still the tree map. I'm just wondering if I can point on here. Can you see my mouse when I move it around on here?
Yes, we can see.
Okay, great. So you can see here I've chosen the measure of disability adjusted life years. So here, this is presenting all of the disability adjusted life year estimates for Indonesia, which you can see here. It's for the year 2023. I've chosen to present it for all ages and for both sexes combined. And you can see here is this box that is giving the results for stroke. So stroke makes up 10.74% of all DALYs in 2023 in Indonesia. And you can see how it compares to ischemic heart disease and other causes of health loss in Indonesia. You select, I have here just chosen the basic settings that you can see up here, and I've chosen this box over here on the left-hand side, tree map. So that is how you would navigate to this. Here we have a map of Indonesia, and I've chosen stroke. So we're now adjust. So the previous tree map was showing stroke in compared to other causes of disability adjusted life years. Here we're just seeing the results for stroke, and we are showing it for, I'm showing it for deaths again in 2023. It is a rate. Here I'm presenting the rate for all ages. So this is not age standardized. This is or not a specific age group. It's the all age death rate. If you were, this is a screenshot, but if you were to have the live version of GBD Compare, you could hover over each of the regions, subnational regions within Indonesia, and get the rate and see how it's compared. So this shows you how stroke death rates are comparing across Indonesia in 2023. How does stroke rank? So the tree map I showed at the beginning gave you kind of the size of the box was estimating, giving you a sense of how big stroke was, but it's a little bit difficult to see where it ranks. So this is a very specific ranking tool. You choose on the left-hand side, this figure here it was showing it for all causes. And as I mentioned, stroke comes up at level 3. So you need to choose level 3. And here we're looking at death rates. And as you'll see, you see the 1990 rank. So in 1990, stroke was the #1 leading cause of death rates. And it's remained the same in 2023. It's still the highest #1 cause of death rates in Indonesia. And you can see the ranking of all of the other conditions below that. You can, if you choose level 4, you can get a breakdown to the 3 different specific types of stroke that we measure within GBD, which we'll come on to in a minute. Here, this map here tells you it's a useful, it's got a heat map. So the higher the color, the higher the rank, and it shows what I've done here is I've chosen all the subnational regions within Indonesia. So you have all of your regions within Indonesia for level 3 causes. And here we're showing disability adjusted life years. So here you can see for the ranking for disability adjusted life years for stroke as it compares to all other regions. If you go along here, so it is the #1 cause of disability adjusted life years for all regions apart from these 3 on the right hand side. And here you can see how the other conditions change and are incomparable. So stroke is essentially the highest, the #1 cause of disability adjusted life years across subnational regions in Indonesia. So really, it's really great that we're talking about stroke today, because clearly it causes an enormous amount of disability adjusted life years in the country, and it's the #1 cause for virtually all subnational regions. So how does it vary by age? Well, I think we probably know stroke is, it's pretty, I think I don't need to tell you that it increases your risk with age. Again, here I've decided to choose deaths as the measure. I'm showing the rates for Indonesia for the whole of the country, very small rates below the age of 44, and then it starts to increase. And here's the first example. You can see here the 3 different types of stroke. So the total rate adding up is all strokes combined, but we also produce estimates for subarachnoid hemorrhage, intracerebral, and ischemic stroke. So you can see that this darker red, hopefully it's possible for everyone to see this, but this darker red is ischemic stroke. So ischemic stroke, it has the highest death rates for all of the 3 subtypes of stroke, and that rate increases quite substantially as you increase with age. So that was all of those estimates previously were not really changing, showing the estimates and how they changed over time. Here on this plot here, I've chosen stroke again. It's disability adjusted life years. If you were interested in incidence and prevalence, you could change to incidence and prevalence. But how is stroke changing over time? And this shows the results from 1990 up through to 2023, our very latest results, and it shows the changes, the decline, and then the slight increase, and then the decline in disability adjusted life years. So since around about 2009, there's started to be a bit of a decline with a change in 2021, and then a decline again. So this allows us to look at how stroke is changing over time, and you can do this at the subnational for each of your regions in Indonesia as well. You can also, as I mentioned, visualize this at the subnational region. So here, instead of doing the disability adjusted life years with a confidence interval for the whole country, here I'm now showing the different rates as they appear for different subnational regions with a general pattern that's quite similar across the regions. And finally, I'm going to finish off with some estimates of risk factors, because these are really important. These are the addressable issues. So on this plot here, I've chosen risk factors as our what we want to look at. I've chosen level 2, and I'm looking at deaths in Indonesia and in 2023. And here we have the 3 different subtypes of stroke, and the risk factors. High blood pressure clearly stands out as being the biggest risk factor for these 3 causes, with tobacco risks second, then dietary risks, and then air pollution, kidney, cholesterol levels, and glucose levels. So this gives you an idea about the underlying risk factors that are the causes of stroke in Indonesia. And we can show how this plot here shows that same one risk, sorry, apologies. It shows the single risk factor, and we're looking at summary exposure level for all of the risk factors due to stroke in Indonesia and how those are changing over time. And then this final plot gives you a sense of how modifiable risk factors attributable to stroke changing in Indonesia. So the biggest group of risk factors is the metabolic risk factors here. We have behavioral and metabolic, behavioral on its own, and then environmental here being a smaller pie, so part of the pie. So the bigger the slice of the pie here, the bigger the risk factor. So this is hopefully really useful, actionable information that you can take on and use. And I'm sure as you're looking through the GBD results, you'll want to be able to share those. So you can click on the shareable links over on the top hand right. You can screenshot it and you can download the underlying data within that. You can also isolate regions, so it's possible to highlight countries within here by choosing this mode here on the left-hand side, and you can change the opacity and take screenshots of this and share it with your colleagues. I'm just going to end with a couple of points. I think the priority set, the GBD compare is really useful for maximizing health impact, and because you can choose the interventions based upon those risk factors that we've been talking about, and you can compare the health outcomes across countries and age groups. And one of the key strengths is that the GBD is able to do that and inform that priority setting and help us challenge and isolate true differences in health outcomes, and not simply measures in the way that differences in the underlying way that these conditions are measured. Okay, that is the GBD offers the solution to be able to do that. Okay, hopefully that has been a useful introduction and to the tools and how you could use those tools. I will stop now and happy to stay around and answer questions.
Thank you. Thank you very much, Professor Aldrich. And thank you very much to all our distinguished speakers for your excellent and inspiring presentations. We now have about 10 minutes for a brief discussion and Q&A session. I invite participants to type their question in the Q&A box, or if time allows, we may take one or two questions probably. Let me check on the Q&A box. Yes, we have a question. For Professor Valerie Feigin and Professor Robert Aldrich, it is a question from Ms. Helena Uliarta. What are the most critical data sources that low and middle income countries like Indonesia should focus on improving to refine stroke burden estimates? Professor Feigin, would you like to give comment first?
Yeah, I think Professor Rob Aldrich showed quite convincingly that GBD data are the best possible data in countries, particularly where no population-based data, no good quality, gold standard quality epidemiological studies are done. It is irreplaceable GBD data. For those countries in particular, and globally, of course, but I would think that GBD data now are very close to the true estimates on the population level, because the quality of GBD data has been improving constantly with more studies published, analyzed, and included in the modeling. And this data source I would recommend to use in Indonesia.
Thank you, Professor. Professor Aldrich, please.
Yeah, thank you for doing my job for me. So I think I obviously agree that it's a fantastic resource. I'm looking forward to, I will say, I will be visiting Indonesia, and we hope a lot of the data that for the team that I lead, we use electronic healthcare records, and we're looking forward to working with colleagues in Indonesia to improve our estimates in Indonesia using your healthcare record data. So I think that is what we hope. I think our estimates, as has just been mentioned, are always getting better with the studies that are published and the surveillance data that is published. And we're very excited to come and visit and improve them even further using your data, because the more data that we have from Indonesia on stroke, the estimates they're probably, as mentioned, they're probably pretty good already, but they will only get better with that additional information. Thank you.
Thank you, Professor. Now, the second question is for Professor Feigin from Ulfati Pertiwi. Professor, you mentioned that high-risk strategies have not been effective in reducing the stroke burden. At the district level in Indonesia, we mainly rely on hypertension and diabetes screening, the entry point. what would you recommend for making our approach more population-wide and cost-effective, even before we have a comprehensive national CVD risk data system?
Yeah, that's a good question. The high cardiovascular risk strategy was proven not effective, not only for stroke, but for other cardiovascular events, including myocardial infarction, peripheral artery disease, incident cases, and so forth. So, and as I showed in my presentation, WHO does not recommend cardiovascular disease screening anymore. I think things will change soon. It's very difficult to change that strategy because initially it was endorsed by the World Health Organization, and now to change it, it's people need to be really open-minded to change it. But what I would recommend, if you focus on hypertension screening for stroke and its prevention, and it's probably quite reasonable because up to 60% of stroke burden is attributable to elevated blood pressure. I would like to emphasize one thing, which often people do not know, that in the GBD study, the high blood pressure is systolic blood pressure over 115 millimeters of mercury, not 140, like a
150,
criteria for
okay.
hypertension, or 115. And 115 and up to 110 is used as a reference variable for that estimate. For detection of people with elevated blood pressure, I would prefer that term rather than hypertension. It's very important. It's very important because the relationship of blood pressure with stroke is linear, and nobody argues with that. But to be effective, prevention, I believe, need to be integral, not just focusing on stroke, because it's quite expensive just to focus on one disease, though number one cause of death and disability in Indonesia. But I would recommend integrative approach. Stroke is a good indicator of effectiveness of any non-communicable disorders because it responds to blood pressure reduction like that. Very much next day, you have a reduction in the risk. And it's like a testing kind of paper for the effectiveness of what you are introducing. But changing lifestyle, and Professor Albrecht showed quite nicely that the contribution of the behavioral factors in the burden of stroke in Indonesia is almost equal to the contribution of high blood pressure. So attention to lifestyle factors like smoking, physical activity, diet, all of this is equally important as hypertension management and control.
Completely agree, Professor. Completely
Yeah.
agree.
Yeah,
Professor
just
Pandian, would you like to
comment
add
here.
something?
Yeah,
Yes.
no, I'll just comment. Recently, the WHO CRO NCD prevention focused on hypertension, diabetes, and for all the health managers, revised target has been set based on the new NCD political declaration that will be approved soon. And so one of the additional things that in the CRO region we are emphasizing is statins. That is another important risk factor, lipids, which has not been highlighted. Of course, we target on hypertension and diabetes control. Even in the risk screening, WHO is shifting in a different way without using lab values. So in the the previous WHO CVD score. There was fasting blood sugar, there was lipids, and so they are moving away from lab value, so that at primary care level, they are trying to pick up low to moderate risk. And so as Professor Fagan had mentioned, there is a shift from WHO, and they are also looking at other interventions. Statin, for the first time I have seen in a big WHO meeting, they're talking about it, and it'll soon will get incorporated at the country level, but it'll take some time. So these, in addition to behavioral risk, and salt substitution is another important area which WHO is recommending, and so the new targets that are going to be set for different countries, and they need to work out their own strategies, how they're going to reduce the NCDs. Yeah, thank you.
Thank you for your comments, Professor. We have one more question from, this is the students from Health Polytechnics of Surabaya, NICMA, to Professor Faigin. Professor Faigin, my dissertation topic is the burden of informal caregivers of stroke patients regarding the development of support systems in communities, especially in Indonesia. What types of interventions would be most effective in improving the health status of both patients and their caregivers?
This is a very big question of what can be done to improve the status of patients, and I think it would require a special session. But briefly, there are a number of international guidelines on the management of stroke patients, and less so for guidelines for management of caregivers. And it is increasingly recognized that the burden of stroke is not limited just to people who have a stroke, but there is a saying even so that stroke affects at least two people, the individual and the spouse or whoever lives with that patient, because it has family impact on caregivers, and the burden of caregivers is underestimated. It's huge, actually, especially in countries where lack of support, organizational, financial, and other types of support for caregivers. In New Zealand, for example, we have a special system for caregivers to have a rest from their loved ones, and they are placed in kind of resort where they can communicate with each other and forget about their problems for some time, and someone from the Stroke Foundation takes care of their patients, of their partners. So it is very important. As I mentioned earlier, there are some resources available for free for stroke survivors and caregivers, and I shared the link to our charitable trust. We provide those resources free of charge. Everyone can access it online, and nowadays with artificial intelligence translation, it could be seen in any and heard in any language, basically. And use it. And there are other resources as well available from the World Stroke Organization, also for caregivers.
Yeah.
Thank
Yeah,
you.
I'll just
Yes,
add
please,
to
Professor.
this. From WSO, the first step that we recommend is the post-stroke checklist, and that has several components for the stroke patients, screening for anxiety, depression, and also for caregivers. If we systematically involve them, in the beginning itself, at the time of discharge, then it'll become easier. We can prevent several of their issues like their post-stroke caregiver burden and etc. And as Dr. Fagan mentioned about several resources, so from Stroke Support Organization of WSO, we have several resources available for the caregivers, which can be used, and they're all free to download if you're a WSO member. Yeah, thank you.
Yes, collaboration between patient and caregivers, very important. So, thank you very much to our esteemed professors, Professor Faigin, Professor Pandian, and Professor Aldrich for sharing your deep expertise and global experience. If I can I give you one simple closing question, if you don't mind? If you could give one simple message to the public about preventing stroke, what would it be? Professor Faigin, you may start first. Just closing question.
All right. Simple answer. Be aware of the risk of stroke, your risk factors, and how to control them. It is highly preventable.
Very good. Thank you, Professor. Professor Pandian, please.
Yeah, so we have a World Stroke campaign called Greater Than Stroke. It's challenging, and that lays emphasis on awareness screening for hypertension and other risk factors, and then taking appropriate treatment. Yeah, thank you.
Thank you, Professor Pandian. Professor Aldrich, please. Oh, you still muted.
Sorry. I was going to say, I'm not a stroke expert. So I will say from our experience in the UK, there was a very successful campaign around recognizing stroke and helping people get early care if they are experiencing the symptoms of stroke. I don't know whether our esteemed professors agree with that, but that's something that struck a very big chord for me from my time in the United Kingdom.
Thank you so much, Professor.
Today's awareness
yes.
is very important. Stroke awareness.
Yes, thank you so much, professors. I believe today's discussion reminds us that high quality data, international collaboration, and practical policy action must go hand in hand to effectively reduce the burden of stroke. With continued partnership and commitment, I believe we can move closer to a future where stroke is not only treatable, but also truly preventable. And together we can turn this vision into reality. So thank you very much once again, Professor Faigin, Professor Pandian, and Professor Robert Aldrich. On behalf of the National Health Policy Agency of the Ministry of Health of the Republic of Indonesia, I would like to sincerely thank all speakers and participants for joining us in this session. Thank you, and have a wonderful day. I now return the screen to the host.
Thank you.
Thank you so much. Thank you.
Thank you.
Pernahkah Anda melihat kecurangan di lingkungan Kementerian Kesehatan? Maupun macam-macam tindakan korupsi lainnya? Laporkan melalui whistleblowing system Kementerian Kesehatan. Whistleblowing system merupakan bagian dari sistem penanganan pengaduan masyarakat terpadu yang memfokuskan pada penanganan dugaan tindak pidana korupsi. Sistem ini terintegrasi dengan KPK. Melalui
Ladies and gentlemen, we will now have a break until 1:30 p.m. Please stay connected to the Zoom room and we will continue with our final discussion panel after the break. Thank you.
Fasilitas ini, identitas Anda sebagai pelapor dapat terjamin kerahasiaannya. Caranya cukup dengan mengetik wbs.kemkes.go.id. Silakan login jika sudah memiliki akun, ketik username dan password Anda. Bagi yang belum memiliki akun, silakan mendaftar pada kolom registrasi. Isikan username yang ingin Anda pakai, bisa nama asli atau nama samaran. Masukkan alamat email aktif Anda, masukkan password. Password sebaiknya kombinasi huruf dan angka agar keamanannya terjamin ya. Kemudian pada kolom konfirmasi password, ketik ulang password Anda. Klik tombol register. Setelah itu, kami akan mengirimkan email untuk aktivasi akun Anda. Silakan klik tombol aktivasi akun, maka Anda akan langsung terhubung pada halaman login. Silahkan login dengan mengisi username dan password yang telah Anda buat tadi. Pada layar Anda akan muncul halaman pengaduan saya. Klik tambah aduan baru pada pojok kanan atas. Klik pada kotak di tengah tersebut, lalu akan muncul form pengaduan seperti ini. Silakan ketik judul pengaduan. Tuliskan uraian pengaduan dengan menjelaskan kasus dugaan korupsi secara rinci. Jika Anda memiliki dokumentasi dari kejadian tersebut, silahkan diisi pada lampiran. Jangan lupa untuk klik pada kolom kirim sebagai anonymous sehingga identitas Anda terjamin kerahasiaannya. Ketikkan kode CAPTCHA, pastikan semua kolom diisi dengan benar, kemudian klik tombol kirim. Semakin banyak petunjuk, data, atau informasi yang disampaikan, maka akan semakin memudahkan petugas untuk melakukan verifikasi terhadap laporan yang disampaikan. Untuk memudahkan tindak lanjut laporan, sekurang-kurangnya laporan harus memuat 3W plus 1H terkait dugaan pelanggaran yang terjadi, yaitu 1. What? Apa dugaan pelanggaran yang terjadi? 2. Who? Siapa yang diduga melakukan pelanggaran tersebut? 3. When? Kapan dugaan pelanggaran tersebut dilakukan atau terjadi? Dan yang terakhir adalah how? Bagaimana detail dugaan pelanggaran tersebut dilakukan? Inspektorat Jenderal Kementerian Kesehatan menghargai informasi yang Anda berikan. Perlu diingat bahwa fokus kami bukan untuk menjatuhkan seseorang, namun untuk menemukan solusi dari permasalahan. Anda bisa memonitor tindak lanjut atas pengaduan tersebut pada laman whistleblowing system. Laporan Anda akan diselesaikan maksimal 75 hari kerja sejak pengaduan diterima. Dengan whistleblowing system, Anda dapat mewujudkan pemerintahan yang baik dan bersih. Salam sehat tanpa korupsi.
Sekarang habis berobat, datanya bisa muncul di Satu Sehat Mobile. Kamu hanya perlu install dan update aplikasimu ke versi terbaru. Satu Sehat Mobile tersedia di App Store dan Play Store. Kemudian verifikasi profil Satu Sehat di fasilitas kesehatan yang terintegrasi dengan Satu Sehat. Ini dia caranya. Siapkan KTP dan datang ke loket pendaftaran. Buka profil dan cek kode akses, lalu input mandiri ke layar atau dibantu oleh para petugas. Petugas akan cek kesesuaian data KTP dengan profil Satu Sehat Mobile kamu. Lalu, profil berhasil diverifikasi, ada tanda centang birunya. Setelah profilmu berhasil diverifikasi, masuk ke resume medis dan buat PIN yang aman untuk mengakses catatan berobatmu. Karena hanya kamu yang bisa mengakses data. Jaga dengan keamanan berlapis. OTP yes, KYC yes, PIN yes. Punya pertanyaan terkait resume medis atau terkendala saat verifikasi profil? Jangan khawatir, kamu dapat mengunjungi link.kemkes.go.id/fitur-RME.
Di era tantangan kesehatan yang kompleks dan sumber daya terbatas, data yang andal menjadi landasan kebijakan yang solid.
Dan hasilnya alhamdulillah cukup baik. Kita berhasil mencapai angka 19,8. Berarti ada penurunan dari tahun sebelumnya 21,5. Capaian kita jauh lebih baik.
Data yang akurat, tepat waktu, dan interoperabel bukanlah kemewahan, melainkan keharusan. Masa depan kesehatan bangsa bergantung pada keputusan yang tepat waktu dan berbasis data. Beban penyakit katastrofis seperti kanker, penyakit jantung, stroke, dan gangguan uronefrologi terus meningkat di Indonesia. Keempat penyakit ini menyumbang proporsi tertinggi dalam kematian dini dan pembiayaan jaminan kesehatan nasional. Tanpa data yang akurat, respons kita terhadap penyakit-penyakit ini akan selalu tertinggal.
Data kami, contoh untuk gagal ginjal saja menyedot lebih dari 2 triliun rupiah APBN per tahun dari anggaran JKN. Jadi sangat besar. Jika kemudian pengobatan dilakukan setelahnya, sementara ini bisa dicegah. Belum lagi kalau kita menghitung cost of inaction, biaya yang timbul karena tidak bertindak, yang juga kalau kita kalkulasi mungkin sangat besar. Biaya yang timbul dari produktivitas yang hilang akibat kematian dini dan juga kecacatan dan juga kurangnya produktivitas. Kemudian beban ekonomi keluarga karena biaya pengobatan jangka panjang. Kemudian juga tekanan fiskal terhadap APBN kita dan sistem jaminan kesehatan nasional.
Ini menunjukkan bukan hanya apa yang menyakiti kita, tetapi juga di mana kita bisa melakukan intervensi secara efektif. Beban penyakit tertinggi saat ini didominasi oleh penyakit tidak menular khususnya kanker, jantung, stroke, dan penyakit ginjal. Penyakit-penyakit ini bukan hanya penyebab utama kematian dan disabilitas, tetapi juga menyedot biaya pengobatan terbesar. Untuk merespons beban penyakit yang terus meningkat, kita membutuhkan sistem registri penyakit yang tangguh dan interoperabel. Saat ini, data kita tersebar di berbagai institusi. Untuk menangkap data yang komprehensif dan berkualitas tinggi dari layanan primer di puskesmas atau klinik hingga layanan rujukan di RSOD atau RSOP, Indonesia harus menginstitusionalisasikan sistem registri penyakit secara nasional. Sistem ini akan memungkinkan pengumpulan dan analisis data secara sistematis sebagai dasar kebijakan berbasis bukti.
But now, in the last 5 years, the numbers of elderly in Indonesia is keep increasing. It's getting equal with the numbers of below 5. So that needs a different technical treatment, right? Because these people, we don't need child specialist or a BGYN, this need a cancer specialist, heart disease specialist, or stroke specialist, because of the burden of disease are different. So what we are doing now, we are working with International Health Matrix Evaluation. This is an organization based in Seattle, and they help many countries to picture the burden of disease is the next 30 years. So this institution opened an office in Indonesia to help us forecast scientifically what will happen in the next 30 years based on our epidemiological evolutions. So now we understand, oh, okay, this is the type of people, this is the type of disease.
Melalui sistem data yang terstandarisasi dan alat analitik global, inisiatif ini akan menyediakan dashboard, analisis, dan wawasan kebijakan memberdayakan semua tingkat pemerintahan untuk bertindak berdasarkan bukti data. Perhitungan estimasi beban penyakit pada tingkat kabupaten kota akan mendukung dan memandu kebijakan fiskal kesehatan yang hemat biaya, proyeksi kebutuhan tenaga kesehatan yang tepat sasaran, dan ketahanan industri farmasi dan alat kesehatan dalam negeri. Data beban penyakit yang akurat, investasi yang tepat sasaran, mendukung ketahanan industri farmasi dan alat kesehatan. Dengan investasi strategis, sektor kesehatan bisa menyumbang hingga 8% PDB nasional dari farmasi, alat kesehatan, dan layanan kesehatan. Untuk mewujudkan tujuan ini, memerlukan koordinasi dan kontribusi yang baik dari seluruh stakeholders, berbagi data, regulasi, dan investasi berkelanjutan. Upaya ini tidak akan berhasil tanpa dukungan seluruh focal point. Kami menyerukan kepada para pemimpin di sektor kesehatan dan lintas sektor lainnya yang strategis untuk mendukung, mengoperasionalkan, dan melembagakan sistem registri penyakit nasional ini. Ini adalah langkah transformatif menuju tata kelola berbasis data yang tangguh. Bersama kita bisa, Satu data untuk kebijakan yang berkualitas. Indonesia maju bersama data beban penyakit nasional. Sistem kesehatan Indonesia siap tidak hanya untuk merespon namun juga untuk memimpin di kawasan. Mari kita bangun Indonesia yang lebih sehat.
Pernahkah Anda melihat kecurangan di lingkungan Kementerian Kesehatan? Maupun macam-macam tindakan korupsi lainnya. Laporkan melalui whistleblowing system Kementerian Kesehatan. Whistleblowing system merupakan bagian dari sistem penanganan pengaduan masyarakat terpadu yang memfokuskan pada penanganan dugaan tindak pidana korupsi. Sistem ini terintegrasi dengan KPK. Melalui fasilitas ini, identitas Anda sebagai pelapor dapat terjamin kerahasiaannya. Caranya cukup dengan mengetik wbs.kemkes.go.id. Silakan login jika sudah memiliki akun, ketik username dan password Anda. Bagi yang belum memiliki akun, silahkan mendaftar pada kolom registrasi. Isikan username yang ingin Anda pakai, bisa nama asli atau nama samaran. Masukkan alamat email aktif Anda. Masukkan password. Password sebaiknya kombinasi huruf dan angka agar keamanannya terjamin ya. Kemudian pada kolom konfirmasi password, ketik ulang password Anda. Klik tombol register. Setelah itu, kami akan mengirimkan email untuk aktivasi akun Anda. Silakan klik tombol aktivasi akun, maka Anda akan langsung terhubung pada halaman login. Silahkan login dengan mengisi username dan password yang telah Anda buat tadi. Pada layar Anda akan muncul halaman pengaduan saya. Klik tambah aduan baru pada pojok kanan atas. Klik pada kotak di tengah tersebut, lalu akan muncul form pengaduan seperti ini. Silakan ketik judul pengaduan. Tuliskan uraian pengaduan dengan menjelaskan kasus dugaan korupsi secara rinci. Jika Anda memiliki dokumentasi dari kejadian tersebut, silahkan diisi pada lampiran. Jangan lupa untuk klik pada kolom kirim sebagai anonymous sehingga identitas Anda terjamin kerahasiaannya. Ketikkan kode CAPTCHA, pastikan semua kolom diisi dengan benar, kemudian klik tombol kirim. Semakin banyak petunjuk, data, atau informasi yang disampaikan, maka akan semakin memudahkan petugas untuk melakukan verifikasi terhadap laporan yang disampaikan. Untuk memudahkan tindak lanjut laporan, sekurang-kurangnya laporan harus memuat 3W+1H terkait dugaan pelanggaran yang terjadi, yaitu 1. What? Apa dugaan pelanggaran yang terjadi? 2. Who? Siapa yang diduga melakukan pelanggaran tersebut? 3. When? Kapan dugaan pelanggaran tersebut dilakukan atau terjadi? Dan yang terakhir adalah how? Bagaimana detail dugaan pelanggaran tersebut dilakukan? Inspektorat Jenderal Kementerian Kesehatan menghargai informasi yang Anda berikan. Perlu diingat bahwa fokus kami bukan untuk menjatuhkan seseorang, namun untuk menemukan solusi dari permasalahan. Anda bisa memonitor tindak lanjut atas pengaduan tersebut pada laman whistleblowing system. Laporan Anda akan diselesaikan maksimal 75 hari kerja sejak pengaduan diterima. Dengan whistleblowing system, Anda dapat mewujudkan pemerintahan yang baik dan bersih. Salam sehat tanpa korupsi.
Sekarang habis berobat, datanya bisa muncul di Satu Sehat Mobile. Kamu hanya perlu install dan update aplikasimu ke versi terbaru. Satu Sehat Mobile tersedia di App Store dan Play Store. Kemudian verifikasi profil Satu Sehat di fasilitas kesehatan yang terintegrasi dengan Satu Sehat. Ini dia caranya. Siapkan KTP dan datang ke loket pendaftaran. Buka profil dan cek kode akses, lalu input mandiri ke layar atau dibantu oleh para petugas. Petugas akan cek kesesuaian data KTP dengan profil Satu Sehat Mobile kamu. Lalu, profil berhasil diverifikasi, ada tanda centang birunya. Setelah profilmu berhasil diverifikasi, masuk ke resume medis dan buat PIN yang aman untuk mengakses catatan berobatmu. Karena hanya kamu yang bisa mengakses data. Jaga dengan keamanan berlapis. OTP yes, KYC yes, PIN yes. Punya pertanyaan terkait resume medis atau terkendala saat verifikasi profil? Jangan khawatir, kamu dapat mengunjungi link.kemkes.go.id/fitur-RME.
Di era tantangan kesehatan yang kompleks dan sumber daya terbatas, data yang andal menjadi landasan kebijakan yang solid.
Dan hasilnya alhamdulillah cukup baik. Kita berhasil mencapai angka 19,8. Berarti ada penurunan dari tahun sebelumnya 21,5. Capaian kita jauh lebih baik.
Data yang akurat, tepat waktu, dan interoperabel bukanlah kemewahan, melainkan keharusan. Masa depan kesehatan bangsa bergantung pada keputusan yang tepat waktu dan berbasis data. Beban penyakit katastrofis seperti kanker, penyakit jantung, stroke, dan gangguan uronefrologi terus meningkat di Indonesia. Keempat penyakit ini menyumbang proporsi tertinggi dalam kematian dini dan pembiayaan jaminan kesehatan nasional. Tanpa data yang akurat, respons kita terhadap penyakit-penyakit ini akan selalu tertinggal.
Data kami, contoh untuk gagal ginjal saja menyedot lebih dari 2 triliun rupiah APBN per tahun dari anggaran JKN. Jadi sangat besar jika kemudian pengobatan dilakukan setelahnya, sementara ini bisa dicegah. Belum lagi kalau kita menghitung cost of inaction, biaya yang timbul karena tidak bertindak, yang juga kalau kita kalkulasi mungkin sangat besar. Biaya yang timbul dari produk
Welcome back, ladies and gentlemen. Now we will begin our third panel session focusing on data integration and policy frameworks for better health governance in Indonesia. This session will be moderated by Bapak Eriando Rizky Septian from Puskapa Universitas Indonesia, with our speakers from Indonesia Statistik, Ministry of Home Affairs, and BPJS Kesehatan. Bapak Eriando, the screen is yours.
Thank you, Mbak Rania. Welcome back, everyone. I hope you all had a good lunch, something delicious, nourishing, and energizing, so we can return to these afternoon discussions with refreshed minds and new enthusiasm. Thank you for your commitment to stay with us throughout the day. Hope you are already in the room. This morning, we learned a lot from various experts about the concept and burden of disease, from cancer registry, from stroke, and from other diseases as well, what it measures, why it matters, how it calculated, some tools developed, and also the lessons that we can draw from global and national practices. In these next sessions, we will shift our focus closer to home in Indonesia. We will look out at the current system we have in Indonesia, our civil registration system, population administration's data, statistics data, especially vital statistics data, health service data, especially from the insurance, from the BPJS, and explore how this system can work together in the future to support accurate, timely, and efficient burden of disease estimations. Our goal here is not to understand not only the technical component, but we also the opportunity for collaborations and interoperability and policy alignment that will allow Indonesia to measure and use burden of disease data effectively in the years ahead. Now in these sessions, we are joined by colleagues from BPS, Statistics Indonesia, also the Directorate of Populations and Civil Registrations, and later on, I heard that BPJS will join later on. From BPJS, we have Ibu Alvina, Mbak Vina, statistician from the Directorate of Populations and Labor Statistics at BPS of Statistics Indonesia. Hopefully, I would like to invite Ibu Alvina to share her insights. Ibu Alvina has over 16 years of experience in population statistics and is currently leading the development of Indonesian vital statistic systems. We've been working together from 2021, if I'm not mistakenly, to develop the first Indonesian vital statistic report that is published last year in 2024. So she is also active, one of my main champion in vital statistics, supporting the shift toward a register-based census and integrated administrative data systems. So her work directly supports the accuracy of populations, denominators, and mortality data essential for burden of disease estimations that we can hope to be happening soon. So Ibu Alvina, please, the floor is yours.
Yeah, thank you, Mas Yando, for your kind introduction. So, good afternoon, colleagues, Ibu Bapa. It's pleasure to be here today in this webinar. So, my name is Alvina Patriani, like Mas Yando said. I'm a statistician from BPS, Statistics Indonesia, and Mas Yando said I also lead Indonesia Vital Statistics System. So, this is initiative and working closely with key Ministry of Home Affairs, Ministry of Health, Bappenas, and also with a partner, including Puskapa. So that's why CRVS is very close to my heart. And I also like to extend my warm greeting to Bapak Muhammad Nur Al-Azhar from Directorate General of Population and Civil Registration, Ministry of Home Affairs, and also Ibu Dwi Martiningsi that will join later on. So three of us is working closely with data, so this will be exciting and truly honored to share this session with both of you. as well work together to strengthen Indonesia's CRPS system. So I will share the policy framework for the civil registration and vital statistics and how it connects to our effort to produce reliable data for burden and disease, particularly for this webinar, how is potential to connect it in the stroke burden estimation. So my presentation will answer in the 5 questions. Why, what, where, how, and who. So I'll begin why CRPS matter. What is urgency and rational? And then move to the precondition and for what a well-functioning CRPS system. And then we'll see where we are now, our Indonesia current situation. And then we'll discuss how we can move forward. And finally, who plays the key roles. So because my background in statistics, maybe the perspective may lean slightly toward to the statistical side. But don't worry, I won't show any complicated number. Instead, maybe I'll focus on the policy aspect and what is game plan moving forward. So let's start with why CRPS matters so much and what make it urgent. Let's start with the definition and context for the civil registration and vital statistics. Maybe not all of you familiar with this terminology. So civil registration and vital statistic is an official mechanism through which government record the key life events, birth, adoption, marriage, divorces, death, and also the cause of death. So this system is essential because establish the legal identity and protect individual rights. So from these records, we hope that government can produce the vital statistics and along with the data on the fertility, mortality, life expectancy, and so on. It is crucial for the policy and planning. So well-functioning civil registration can contribute to over 72 of the 230 SDGs indicators. But in many countries, CRPS maybe doesn't exist, or there is exist, but fails to generate complete or reliable vital statistics. So often people pay attention for the birth registration, but overlook for death registration. So I want to emphasize for the death registration, when it goes unregistered, especially without knowing the cause, so we lose more than a record. We lose the story behind that life and the chance if we don't record the cause of death, we lose the chance to prevent similar deaths in the future. So that's why CRPS matter is not just about recording event, but it's about understanding and protecting people. Now let's see how the international declaration in the Ministerial Declaration on a Decade of Action for Inclusive and Resilient CRPS that conducted last June in 2025. So this event reaffirmed 3 key points. The first is millions of births and deaths remain unregistered in Asia Pacific and also in Indonesia. So living individuals without legal identity and country without a complete data. So the absence of the reliable and timely vital statistic limits evidence base for planning and for policy making. So don't be blind leading blind data. It's a compass for us. And there is opportunity for digital transformation. It's offer a real opportunity to build secure, inclusive, and interoperable system. And through this declaration, countries have committed that by 2030, 100% birth and at least 80% of death should be registered. And now, where does Indonesia stand in this journey? I would like everyone to see or to learn from some country. And I really hope that Indonesia will will not be left behind. So I choose some countries. There is country that shift from paper-based to the digital system, like Sri Lanka. And then there is some here in the list, advanced digital system, South Korea, Japan, New Zealand, Australia, and the Netherlands. And sometimes we also say that Indonesia is big, is unique. Yeah, but that's why I choose China, because this is the country with the big population. But this country have one thing in common. They have a strong coordination across institutions, and they are willing to collaboration, to share, to build the system. So as seen in this orange word here, there is share, report, link, integration. So that's a key message. So I believe that the sharing, interoperability don't happen by chance. They happen because institutions trust each other and coordinate clearly. And the benefits also clear. We see here that timely health policy information, and then fewer burden on citizens, like in Singapore. So citizens don't need to report the same event to the multiple offices. And from statistics side, I would like to learn from Netherlands, because they conduct virtual census and more greater efficiency. So the last census door-to-door or field data collection base the last is 1971. And then for this method, virtual census, the cost less than €1 per person or per capita. So it's around 2,000 rupiah per capita. So imagine how much we could save the data with full integration. And from this country, we can learn that integration is feasible also with Indonesia, because we have very good digital CRVS and centralized, and then we have national ID NIK. Not every country has NIK, not every country has population register, but Indonesia already exists. And we can start like Sri Lanka, where the data already exists, to inform from civil registration data to the health sector. And then there is clear mandate. There is a strong regulation in this country. And also, I also hear that listen in this morning from several experts, the word investment. So investment are needed in the civil registration. And integration in between health and civil registration, I would say it's not optional, but it's a necessity. But for Indonesia, we can work in gradually, step by step. And then before we move to our game plan, now let's first understand what needs to be in place or the precondition for a well-functioning CRPS system. Yeah, from some UN recommendation, this is an essential building blocks, legal framework to defining the vital event, the roles and data use, and then institutional arrangement or collaboration. So designated authority with coordination with registration, health, and statistics. And because we have a good civil registration that is continuous, permanent, compulsory, and universal, I think we have met the standard. And we need the operational enabler, like a completeness and timeliness, to make all events registered fully and promptly, with the standard definition and classification, aligned with the UN recommendation. And there is evaluation and feedback. And then for the cost of that, in Indonesia, to the civil registration, the cost of that is based on the recall of the family member, not based on the certified medical certification. The cost of that must be stated or must be sure that it's come from the medical authority. And then another enabler is about the data integration, and to make sure data integration is aligned with the data protection, to ensuring that the record can be linked securely across agency. So there are the foundation to make the civil regulation and for producing a vital statistic. Now let's see how Indonesia doing in these elements. For the legal and regularity gaps, so Indonesia has a long legal instruments covering statistic law, population administration law, data protection law, and one data policy. And however, with this law, the mainly regulate, there is a regulate data collection and sharing, but not yet individual level linkage and not for the vital statistics. So we need very clearly that this is the law will be for the vital statistic purpose also. So once we had a good relation on CRPS, but it's not longer effective or expired in the last year. That's from the legal and regulatory gaps. And then now see about the completeness and timeliness. Mas Yando mentioned that we already produced 5 statistic report. So there are 2 key findings here, that many children are not registered immediately after birth, and then many deaths are still unrecorded. So for deeper analysis, we use 3 approaches to assess the completeness: statutory period, year 0, and up to cutoff date. Statutory period is measure the event report within legally mandated time frames. So for birth within 60 days, and for death within 30 days. Year 0, this measure for event that occurred in the specific year and were registered within the same year. So year 0 is shown by the orange line. So let's say for birth in 2019 that occurred in that time, 2019, and register same in the same year, 2019, is about 45%. And then the other approaches is up until cutoff date to capture all event register up to the predefined cutoff date. In this report, we use March 2024. So the conclusion or the finding for this number is birth registration completeness is projected to exceed 90% by the 5th year, typically when the child enters school. And then for the registration, remain lows or around 60%. We can see here until cutoff date, the date that occurred in 2019 only register 64%. Another important point is that refugees and stateless persons remain legally invisible in the Indonesia admin data system. Data requirement and standard. So we have recommendation or guidance from UN. Indonesia has valuable civil registration system with rich variable and well-designed form, and many of the form is aligned with the recommendation, such as sex, death, birth attendance, and so on. But when we sit together and we analyze data together, and we found some critical variable that's shown in this orange on this slide cannot yet be generated properly. This happened because simply because different definition with the standard, international standard, or because the open text in the application, so we cannot process further at the time. Yeah, this is understandable because civil registration is not designed for statistical purpose, but to make the shift that some system not only for admin but can be utilized for statistical purpose, this takes time, but it's possible if we continue for open discussion and collaboration. So I make it bold there for usual residents. So this is important for usual resident because to create the indicator, fertility indicator, mortality indicator, we must calculate in the usual resident concept. So I will show why this is matter. From 2020 population census, we come with the one question: how many people actually live at the same address as on the ID card, like KTP or Kartu Keluarga? So the result is about 8.7% or around 20-30 million people. It's big. It's same with the population of Sri Lanka. So they live at different address. So imagine if 20 million people were misplaced in the data. So how many social or health program could be mistargeted? Okay, I will give some example what this is matter. Take example for Yogyakarta. Yogyakarta is student city. So if you are the health planner, how many doctor, how many hospital, how many transportation to be built there? Are you do you plan with only Yogyakarta people with ID Yogyakarta only, or with the student? So of course not. We have to blend for both, for people with the ID Jogja and for the student, because student also live there and use the city services for health, transportation, and so on. Another case is migrant worker. How many Indonesian citizens that live abroad for student, for work, and so on? And then how many foreigner that stay or live in Indonesia? So we need that kind of information. But because we ask or we question when we work together in the vital statistic report, and we cannot answer this question because we only use civil registration data. To answer that question, we need more data to make sure or to answer that question: how many people that live in this or one place? Okay, now after we see the gaps, and now let's talk about the way forward. How Indonesia plan to move forward.
3 menit lagi ya, Mbak.
Yep. Yeah, this framework has developed based on the UN principle and recommendation for vital statistics. This is aligned with general statistical business process model, covering all stages from specified needs to collection, production, dissemination. And this has been discussed from April and issuing to the Ministry of Law, and it become a legislative program in the next year. So in this picture, we can see that every event is managed by several agencies, both at national and subnational level. So the proposed mechanism is simple, that every institution at the first is verified the NIK first, and then send notification to the Ministry of Home Affairs, and then follow up by Dukcapil at the subnational level. And then when the system are connected, the certificate will be issued automatically. For this chain, the review or the streamlining of business process will be led by Ministry of Home Affairs. And then the other chain, for the vital statistic production, so BPS has two main roles. The first is to count the number of vital events. It will be using the SIAC data as the main sources because it's already contain detail and the event characteristic. And then for the rate, fertility, mortality, we need the total population. That's why we need to integrate all the multiple sources to calculate the total population. So we aim to make all the system interoperable within BPS environment. We call it statistical registration system that link with statistical population register, statistical business register, and location register. So once we establish the population spine, we can link with the health data that edit cause of death or morbidity to create complete picture connecting identity, health, and statistics. And then what is the role or for each party? So in this this opportunity, I will want to zoom it a bit on the role of each agency, especially when we talk about connecting health data. So this is for the health sector. We have another sector like marriages and divorces. So MOHA will lab registration services and how it's connected with all relevant agency and to make sure that birth and death are registered in a timely manner. And then Ministry of Health manages the cost of data and morbidity information and leads the data with BPJS and the health facilities. And BPS ensure the integration and data quality, the standardized, and then we produce frequent vital statistic, population statistic, socioeconomic statistic that can be linked to the health data. But and then BSS and Ministry of Communication will guide us about security. Also, we need academia partner to provide analytical and technical support. But the main message is simple, we cannot work alone. So to conclude, I have 5 points. A strong policy framework is essential to translate global commitment into national action. So each institution must play its role within its mandate. Register, health, statistics must move together toward a shared goal. And then interoperability data, I believe, that must start at individual level to ensure policy precision and build a sustained, efficient, and modern statistical system. Interoperability with civil registration and health system must be accelerated. And yes, Indonesia is too big to wait because 2030 is just around the corner. And finalizing the presidential regulation on vital statistics is strategic milestone. It's a strategic step to build an integrated system to ensure reliable data, especially if want to have a burden of disease dissemination. And the last, learning from partner and global experience is to strengthen our direction. So thank you so much for the opportunity to share today. I sincerely hope that your continued support and collaboration so this initiative can move forward and bring real impact. If you like to learn, please contact myself. So we are open to collaboration, joint project and research regarding CRPS. Thank you so much. Back to you, Mas Yando.
Thank you, Mbak Vina. Very nice explanations and presentation from you. Alvina already shared her works in CRVS, also some recommendations that is really needed for future collaborations between ministry. Now we also have Ibu Hera here, Hera Mutiara. Ibu Hera plays a key role in managing population administration information system in Dukcapil. Her work ensures that reliability of identity data, biometric uniqueness, and civil registration records are crucial foundation for ensuring every life event, including that, is recorded accurately for public health analysis. Ibu Hera is also really supportive of us, even though we haven't met during our last work in vital statistics last year, but she and her team is really do the work for the first production of vital statistics last year. Ibu Hera, are you with us now?
Siap, Mas Yando.
Thank you, Ibu Hera. 15 minutes for you. The floor is yours.
Oke, siap. Izin menyampaikan dalam bahasa Indonesia ya. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih Mas Yando, Mbak Raina, kemudian Mbak Alvina juga. Kita bertemu lagi Mbak Vina. Izin kami dari Ditjen Kependudukan dan Pencatatan Sipil ingin menyampaikan mengenai bagaimana pengelolaan informasi administrasi kependudukan. Bisa langsung ditampilkan bahannya, Mas Samsul? Baik, pengelolaan informasi administrasi kependudukan. Jadi selama ini kita hanya mengenal bahwa Dukcapil itu hanya mengurus KTP dan KK saja. Tapi di balik itu sebenarnya ada suatu bisnis proses besar di mana menghasilkan data yang saat ini sudah dinikmati lebih dari 7.000 lembaga pengguna. Jadi awalnya dari penduduk yang mengurus dokumen kependudukan kepada Dinas Dukcapil di seluruh kabupaten kota di seluruh Indonesia. Kemudian datanya di-entry, diterbitkan dokumennya, dan menghasilkan data demografik dan biometrik. Karena di Dukcapil itu tidak hanya data teks saja, tapi kami pun merekam data biometrik. Nah, kemudian dari Dinas Dukcapil itu agak sedikit berbeda dengan dinas-dinas yang lainnya di tingkat pemerintahan daerah, di mana Dinas Dukcapil pejabatnya itu diawasi dan SK-nya langsung oleh Direktorat Bina Aparatur di Ditjen Dukcapil. Sehingga perpindahannya, kemudian mutasinya, semuanya diawasi, termasuk juga kinerjanya. Nah, ini untuk menjamin kualitas baik dari pelayanan, kemudian juga dari sisi pemanfaatan datanya juga. Nah, kemudian dari data-data hasil pelayanan dari daerah itu dikirim secara langsung ke pusat melalui jaringan komunikasi data, dikirim ke data center yang ada di Kementerian Dalam Negeri. Kami memiliki 3 data center yang memiliki fungsi masing-masing, yaitu untuk menampung biometrik, menampung data teks, juga yang satunya adalah untuk data recovery centernya. Nah, dari data yang sudah terkumpul inilah, dari sistemnya, aplikasinya, pengelolaan datanya, ini ditangani oleh pengelolaan informasi administrasi kependudukan. Nah, data-data ini sejak tahun 2022 dapat kami sampaikan bahwa kami sudah migrasi yang tadinya itu sistemnya terdistribusi di masing-masing daerah menjadi terpusat. Jadi database-nya ditarik dari masing-masing kabupaten kota dijadikan satu di data center Kementerian Dalam Negeri. Jadi posisinya di daerah adalah sebagai klien. Nah, kenapa itu dilakukan? Karena pertimbangan keamanan informasi. Jika datanya masih tersebar di 514 kabupaten kota, maka kami harus memperhatikan keamanan 514 titik. Nah, dengan demikian, dengan kondisi yang sangat berbeda-beda, baik dari sarana prasarananya maupun SDM-nya, maka kami menarik menjadi satu titik besar di data center Kementerian Dalam Negeri. Nah, itu juga untuk mendukung verifikasi identitas kependudukan, di mana setiap perubahan data yang dilakukan daerah, itu akan mengubah langsung data yang ada di pusat. Jadi jika ada pelayanan di BPJS Kesehatan misalnya, jika ada penduduk yang pindah, sudah mengurus pindah di kabupaten kota, maka datanya akan langsung berubah. Jadi yang data yang diakses oleh BPJS itu adalah data yang terakhir kali sudah diupdate oleh operator daerah. Nah, dari data yang sudah kita olah, diantaranya kita gunakan untuk alokasi anggaran, kemudian perencanaan pembangunan, termasuk juga untuk statistik hayati yang tadi sudah disampaikan oleh Ibu Alvina dari BPS. Nah, intinya sebagian besar dari lembaga pengguna yang menggunakan data kependudukan, sebagian besarnya itu adalah untuk pelayanan publik, untuk verifikasi identitas kependudukan. Yang ditangani untuk lembaga pusat itu adalah Direktorat IDKN, yaitu Integrasi Data Kependudukan Nasional, sedangkan untuk tingkat daerah ditangani oleh Direktorat IDKD, Integrasi Data Kependudukan Daerah. Nah, dari macam-macam pemanfaatan data, termasuk tadi pelayanan publik, perencanaan pembangunan, termasuk juga untuk penegakan hukum. Kemudian ada satu hal penting yang mungkin memang tidak dimiliki oleh lembaga lain, yaitu kami menunggalkan datanya itu dengan dasar biometrik. Kenapa menggunakan biometrik? Karena dari situlah penunggalan datanya itu dilakukan. Karena kalau misalnya hanya mengandalkan data teks, banyak penduduk yang masih mengakal-ngakali supaya memiliki KTP lebih dari satu. Jadi diubahlah tanggal lahirnya, diubahlah tempat lahirnya, kemudian namanya juga sedikit diubah-ubah, ada yang disingkat, ada yang dipanjangkan. Jika tidak menggunakan verifikasi biometrik, maka itu akan menimbulkan yang namanya data ganda. Nah, dengan adanya verifikasi penunggalan biometrik, maka walaupun data teksnya diubah-ubah ataupun penampilan secara fisiknya atau misalkan ada yang rambutnya ada yang dicukur, ada yang gondrong, ada yang pendek, seperti itu, ada yang tua, ada yang muda. Selama biometriknya itu sama, maka itu akan teridentifikasi sebagai orang yang sama. Jadi kita melakukan perekaman wajah, sidik jari, dan iris mata. Nah, dari situlah nanti kita akan menghasilkan data mana yang tunggal dan mana yang duplikat. Kemudian dari dasar seperti itu, kita akan mengeluarkan atau menerbitkan data kependudukan per semester. Jadi, menurut undang-undang, kami menerbitkan data kependudukan itu 1 tahun 2 kali. Next. Yang pertama itu di bulan Juni, kemudian yang kedua itu di bulan Desember. Nah, untuk tahun ini data yang terakhir kali kami terbitkan adalah posisi semester 1 tahun 2025. Next slide. Nah, ini jumlah penduduk di tahun 2025 semester 1 posisinya di 286.693.693 jiwa. Nah, inilah yang kami terbitkan, kami juga bersihkan, yang anomali, yang ganda kami sisihkan, termasuk juga dari hasil penunggalan biometrik yang tadi. Jika misalkan ada penduduk memiliki lebih dari 1 NIK, maka jika statusnya duplikat itu tidak kami hitung sebagai jumlah penduduk. Nah, dari data-data tersebut setelah diolah itu akan menghasilkan 2 jenis data. Next, yaitu data agregat dan data individu. Nah, bagaimana kita bisa memanfaatkan data-data agregat tersebut? Tentunya kalau misalkan untuk webinar pembahasan siang ini untuk perencanaan kesehatan. Next. Nah, dari data yang sudah kita terbitkan tersebut, kita bisa bagi misalkan berdasarkan struktur umur. Kemudian juga bisa kita bagi mana usia produktif, mana usia tua, mana usia muda. Nah, ini mungkin bisa membantu Bapak Ibu di Dinas Kesehatan dan di Kementerian Kesehatan untuk melihat kira-kira usia-usia mana yang rentan terkena penyakit berat, misalkan seperti stroke, seperti itu. Nah, dari sini kita bisa menyajikan data-data dari seluruh Indonesia, baik dari tingkat nasional sampai per desa kelurahan. Kita bisa bagi berdasarkan struktur umur. Nah, ini bisa mendukung untuk perencanaan, alokasi anggaran, juga untuk melakukan analisa kebutuhan, kemudian analisa kira-kira mana usia-usia tertentu yang cenderung punya risiko penyakit tertentu, seperti itu. Next. Nah, kemudian di kami juga ada yang namanya itu data kematian. Data kematian yang berasal dari penerbitan akta mati. Dari penerbitan akta mati tersebut, ada yang namanya itu kolom tanggal lahir, kemudian tanggal meninggal, juga tanggal diterbitkannya akta. Nah, dari kolom-kolom tersebut kita bisa eksplor lebih dalam kira-kira data apa yang bisa kita sajikan untuk membantu analisa Bapak dan Ibu. Misalkan yang ada di sini, kalau misalnya kita lihat dari data yang meninggal tahun 2024 dan 2025, ternyata yang paling tinggi penduduk yang melaporkan meninggal ke Dinas Dukcapil, paling tinggi itu usia lebih dari 74 tahun. Nah, itu usia yang paling tinggi dilaporkan meninggal. Kemudian berikutnya antara usia 60 sampai 64 tahun. Nah, ini kita bisa lihat lagi, misalkan penyebabnya seperti apa, penyebab kematiannya. Next. Kemudian jika dari pelaporan kematian di seluruh Indonesia, dari yang diterbitkan akta kematiannya tahun 2024, memang yang paling tinggi persentase pelaporannya itu ada di Pulau Jawa. Nah, mungkin memang di sini memang penduduk paling padat itu memang ada di Pulau Jawa, sehingga mungkin itu yang sangat mempengaruhi kenapa bisa sampai 62,93% itu berasal dari Pulau Jawa untuk penerbitan akta kematian tertinggi. Baru kemudian disusul oleh provinsi-provinsi yang lainnya. Nah, mungkin ini perlu ada analisa mendalam penyebabnya kenapa dari provinsi-provinsi lain cenderung lebih rendah untuk pelaporan akta kematiannya. Next. Nah, memang untuk di Dinas Dukcapil, untuk pelaporan kematian dari penyebab kematiannya itu sendiri memang sangat terbatas. Jadi hanya ada 6 penyebab, yaitu sakit biasa tua atau pandemi, wabah penyakit, kecelakaan, kriminalitas, bunuh diri, dan lainnya. Karena memang ada pertimbangan-pertimbangan tertentu kenapa kami batasi penyebabnya tidak sebanyak dari yang seharusnya dibutuhkan, baik misalkan untuk statistik hayati ataupun untuk kesehatan. Jadi pertimbangannya itu karena memang formulir yang biasa diisi, yang harus diisi oleh penduduk ketika melaporkan akta kematian, memang dibuat sesimpel mungkin. Karena jika misalnya kita sajikan penyebab kematian yang sangat banyak itu, takutnya itu penduduknya menjadi bingung. Karena tidak semua penduduk kita itu tentunya pendidikannya itu tinggi, sehingga untuk diberikan formulir yang singkat pun mereka malas lapor, apalagi kalau misalnya kita berikan pilihan-pilihan yang terlalu banyak. Nah, tapi nanti kita bisa melakukan opsi-opsi atau alternatif lain sehingga kita bisa mengetahui informasinya bisa menjadi lebih kaya. Tidak hanya misalkan memaksakan untuk menambahkan banyak penyebab kematian di formulir pengajuan akta kematian. Nah, ini untuk data agregat. Nah, kemudian lebih lanjut untuk pemanfaatan data detail atau data by name by address. Nah, karena untuk keamanan informasi, tidak ada yang namanya penyerahan data by name by address secara gelondongan ke pihak manapun, kecuali yang disebutkan oleh undang-undang, seperti undang-undang pemilu. Itu sudah disebutkan secara jelas. Nah, tetapi untuk alasan lainnya itu tidak ada. Nah, bagaimana cara memanfaatkan data tapi tanpa share data by name by address, kami memiliki beberapa metode. Yang pertama itu sebelumnya. Yang pertama itu untuk akses NIK, ini kita menggunakan web service. Web service di mana koneksinya itu melalui API dan menghasilkan status verifikasinya itu data tidak ditemukan, kalau misalnya NIK-nya memang tidak ada, kemudian itu ada data yang sesuai dan tidak sesuai. Nah, ini sesuai dengan rekomendasi dari rekan-rekan kita di BSSN untuk menjaga keamanan data. Ini metode yang pertama. Kemudian metode yang berikutnya, next. Metode yang berikutnya adalah menggunakan web portal. Jadi portalnya, aplikasinya kami yang membuat, lembaga pengguna baik pusat maupun daerah tinggal mengaksesnya saja. Mengaksesnya, kemudian mengetikkan NIK-nya, kemudian tampil sesuai dengan elemen data yang disebutkan di perjanjian kerjasama. Nah, kemudian next. Selain itu juga ada akses untuk card reader. Jadi card reader ini rata-rata digunakan oleh bank. Jadi untuk mengecek keaslian dari KTP yang dipegang oleh penduduk. Jadi mengecek karena di dalam KTP elektronik, di dalamnya itu ada data-datanya. Jadi ada data sidik jarinya, kemudian juga ada isinya ada nama, tempat lahir, NIK, kemudian alamat dan segala macam di dalamnya. Jadi itu untuk mengecek keaslian apakah KTP-nya itu asli atau tidak. Kemudian next. Nah, berikutnya ini adalah face recognition. Jadi verifikasinya melalui pengenalan wajah. Nah, hasil dari perekaman KTP elektronik salah satunya itu adalah melakukan foto wajah. Nah, dari foto wajah inilah kami manfaatkan untuk sebagai sumber data verifikasi. Nah, yang pertama untuk face recognition itu adalah untuk 1:1, kemudian yang kedua adalah 1:N. Nah, yang untuk 1:1 ini dari lembaga pengguna melempar NIK, kemudian fotonya baru dikirimkan ke kami. Baru kemudian kami akan kirimkan berapa persentase atau nilai dari kemiripan wajahnya. Nah, kemudian yang berikutnya adalah 1:N. 1:N ini di mana hanya dilempar foto saja, baru kemudian kami akan kirimkan beberapa pilihan dari skor yang tertinggi. Nah, biasanya untuk 1:N ini digunakan untuk para aparat penegak hukum seperti Bareskrim Polri. Seperti itu. Nah, kemudian yang terakhir ini pemanfaatan yang paling baru adalah identitas kependudukan digital. Nah, ini juga yang sudah digunakan oleh aplikasi Satu Sehat, sudah kita integrasikan untuk identitas kependudukan digital. Nah, ini ke depannya itu bisa berkembang lebih banyak lagi dari identitas kependudukan digital ini. Di sini juga kita sudah sediakan di mana ada menu yang namanya itu menu pelayanan. Jadi penduduk bisa request pelayanan untuk misalkan mendapatkan kartu keluarga, request pindah, request akta lahir, kemudian request KIA, kemudian request yang dokumen-dokumen yang lainnya, itu ada di identitas kependudukan digital. Nah, ini salah satu usaha kami, upaya kami untuk meningkatkan pelaporan perubahan data yang ada di masyarakat. Jadi supaya mempersempit atau mengurangi kedatangan langsung ke kantor dinas Dukcapil, seperti itu. Jadi cukup mengirimkan semua persyaratannya itu melalui identitas kependudukan digital. Nah, kemudian itu yang akses melalui sistem. Ada lagi satu yang dimana kita lakukan verifikasinya itu secara besar sekaligus. Namanya adalah pemadanan data. Nah, pemadanan data ini dilakukan biasanya itu untuk verifikasi data awal. Verifikasi data awal, misalkan Bapak dan Ibu memiliki data, misalkan ada jumlahnya 1000. Nah, dari 1000 itu bisa langsung diberikan ke kami, baru kemudian kita padankan ke data keseluruhan di Indonesia. Jadi bisa dipadankan berdasarkan NIK, nama, kemudian jika ada elemen tempat lahir, kita juga padankan juga. Jika ada tanggal lahir, kemudian nama ayah, nama ibu, itu bisa kita padankan dengan berbagai jenis kombinasi berdasarkan kesepakatan. Misalkan kesepakatan untuk kemiripan nama diambilnya itu sampai 90%, yang kita proses. Jadi misalkan NIK-nya sama, kemudian namanya kemiripan sampai 90%. Karena bisa jadi, karena ada kesalahan pengetikan, ada perbedaan satu huruf. Nah, perbedaan satu huruf biasanya masuk ke kemiripan 90%, seperti itu. Nah, jadi data ini fungsinya itu adalah untuk memadankan secara gelondongan, secara sekaligus dalam skala yang biasanya besar, mulai dari ratusan, ribuan, sampai dengan ratusan juta. Jadi ratusan juta, terakhir kami memadankan data DTSEN, itu total 600 juta record, yang berasal dari 3 data besar yang kami peroleh dari BPS. Nah, itu yang sudah kami lakukan untuk pemadanan. Nah, jadi untuk ke depan, untuk memaksimalkan terutama misalkan kebijakan tadi penyakit stroke misalkan seperti itu, kita bisa lakukan pemadanan. Kalau misalnya dari Kemenkes, Pusdatin Kemenkes, kemudian ataupun misalnya dari Bapak Ibu di Dinas Kesehatan, dari rumah sakit memiliki data, lebih bagus kalau memang dikoordinir oleh pusat, oleh Kemenkes, kita bisa lakukan pemadanan untuk mencarikan NIK-nya yang benarnya itu berapa. Karena jika misalnya sudah dipasang NIK yang benar, maka data tersebut bisa connect ke data-data yang lainnya. Jadi bisa ngecek status BPJS-nya, bisa ngecek NPWP-nya, kemudian juga bisa kita cek juga informasi yang ada di data kependudukannya. Misalkan alamatnya, domisilinya di mana, kemudian dia meninggalnya itu tanggal berapa. Nah, barulah nanti data yang dari Bapak Ibu bisa melengkapinya itu dengan penyebab-penyebab kematiannya yang lebih detail. Seperti misalnya kena stroke, darah tinggi, dan segala macam. Nah, kemudian jika sudah terbentuk data secara utuh seperti itu, barulah bisa kita analisa. Analisa lebih kompleks lagi, menghasilkan agregat-agregat yang lebih lengkap untuk menyusun perencanaan-perencanaan pembangunan ke depannya. Nah, ini untuk pemadanan di awalnya, baru untuk data-data barunya bisa lakukan akses secara sistem. Seperti yang sebelumnya saya sampaikan, bisa melalui web service, web portal, bisa card reader, maupun identitas kependudukan digital. Atau bisa melalui face recognition juga. Nah, ini yang nanti ke depan bisa kita lakukan, bisa kita jajaki. Kalau misalnya kita bisa melakukan pemadanan. Tentunya mungkin kalau misalnya ada data rekamedik. Nah, rekamedik kebetulan kalau tidak salah itu belum pernah kami lakukan pemadanan. Jadi seperti itu. Biar kita mendapatkan basis data yang jelas dulu NIK-nya. Kalau sudah jelas NIK-nya berapa, maka si kunci NIK ini bisa dipakai untuk mengecek seluruh status-status yang ada di kementerian lembaga lainnya. Nah, kemudian terakhir kami juga memiliki call center. Kalau misalnya ada penduduk yang mengalami kesulitan mengenai data kependudukan, akses data, nah ini bisa menghubungi call center di nomor 168. Nah, 168, kemudian juga ada live chat-nya di website kami. Tapi mohon maaf, kalau untuk layanan WhatsApp-nya masih dalam proses maintenance, tapi untuk yang lainnya, untuk call center-nya, live chat-nya itu sudah berfungsi, silahkan digunakan. Jika ada pertanyaan-pertanyaan atau melakukan pengecekan data, misalkan ada yang datang ke rumah sakit, ketika dicek NIK-nya itu tidak ditemukan, nah itu bisa kita lakukan pengecekan. Karena ketika NIK tidak ditemukan itu banyak penyebabnya. Ada yang salah ketik, ada juga yang misalkan memang NIK-nya itu sempat dinonaktifkan oleh operator Dinas Dukcapil dengan berbagai sebab, atau bisa juga karena dia itu adalah duplikat. Jadi sebenarnya sudah punya data di tempat lain, di mana status tunggalnya itu ada di daerah lain, seperti itu. Jadi banyak penyebab yang baru diketahui ketika sudah dilakukan pengecekan langsung ke data Dukcapil, seperti itu. Baik, demikian yang dapat kami sampaikan dari Dukcapil. Mohon maaf jika terdapat kesalahan penyampaian. Mari kita berkolaborasi untuk membangun negeri yang lebih baik di masa yang akan datang. Assalamualaikum warahmatullahi wabarakatuh. Kami kembalikan ke Mas Yando.
Yeah, thank you, Mbak Hera. Thank you very much for your presentations. I think it's interesting to see that Dukcapil already has a strong foundational system for population administrations, including unique identifications, biometric recording, that can be utilized to reduce the duplications, also the data available and aggregates, and can be utilized for pemadanan synchronizations within across ministries. So that is something that we can potentially discuss between us to enable a system for measuring the burden of a disease. Now to our third from BPJS, third presenter from BPJS, Ibu Dr. Dwi Martiningsi. As she is with deep leaderships in and experience in health financing and data at BPJS Kesehatan. Dr. Dwi is also leads the integrations and use of health service data within the national health insurance systems. Also, we would like to know her perspective and exploring how routine the health data can complement civil registrations data to generate meaningful burden of disease insights. This is very interesting presentations. Ibu Dwi, Dr. Dwi, are you already with us? We cannot hear you yet. We can see your screen, but we cannot hear you yet. Dr. Dwi? Does someone from BPJS can confirm about Dr. Dwi? Is she already available or not?
Halo, ya.
Okay,
Aduh, ya.
finally. Thank you, Dr. Dwi.
Maaf, ya, I'm
Yeah,
sorry, ya.
please, floor is yours for 15 minutes.
15, baik ya. Saya pakai bahasa Indonesia izin. Assalamualaikum warahmatullahi wabarakatuh. Saya Dwi Martinisih, Deputi Direksi Bidang Manajemen Data di Direktorat Teknologi Informasi BPJS Kesehatan Pusat. Kami akan menyampaikan tentang interoperabilitas data antara BPJS Kesehatan dengan Kementerian Kesehatan dan kami akan sampaikan tentang dashboard program JKN. Ya, seperti sudah diketahui ya bahwa BPJS saat ini kepesertaannya mencapai 282 juta atau lebih dari 98%, dan dalam ekosistem program JKN kami berkoordinasi dengan kementerian dan lembaga lain, jadi kami sudah interoperabilitas, saling memanfaatkan bertukar data. Ini sampai dengan saat ini ada 40 kementerian lembaga. Kemudian ada 33.000 lebih fasilitas kesehatan sudah saling memanfaatkan dan mengisi data tersebut. Kemudian di channel pembayaran lebih dari 900.000 dan badan usaha lebih dari 320.000, dan dari aplikasi yang kami sediakan lebih dari 30 aplikasi yang bisa diakses oleh para pemangku kepentingan yang berkaitan dengan BPJS. Ini adalah ekosistem layanan kesehatan. Jadi semua perjalanan atau patient journey ini terintegrasi dalam aplikasi. Mulai dari pertama pasien mendaftar, kemudian membayar iuran, melakukan pelayanan kesehatan di fasilitas kesehatan, kemudian bahkan menyampaikan keluhan, kemudian rumah sakit, Vaskes mengajukan klaim, kemudian BPJS melakukan verifikasi dan melakukan pembayaran di bank, semuanya terhubung dalam suatu sistem, suatu aplikasi. Data yang masuk ke tempat kami per detik itu 1.746 per detik. Dan sampai dengan saat ini lebih dari 600 miliar data yang kami kelola. Data ini sangat penting untuk digunakan oleh semua pihak, dan kami akan sampaikan secara khusus interoperabilitas data antara BPJS Kesehatan dan Kementerian Kesehatan. Mengingat bahwa Kementerian Kesehatan ini mempunyai program-program yang diakses atau diberikan pelayanannya kepada seluruh masyarakat dan khususnya fasilitas kesehatan, maka operabilitas data ini akan memberikan akses juga kepada stakeholder tersebut. Jadi interoperabilitas data adalah integrasi sistem atau aplikasi sehingga dapat berbagi, bertukar, dan menggunakan data secara cepat dan akurat. BPJS Kesehatan ada interoperabilitas dengan Kementerian Kesehatan, ini dilakukan melalui berbagai macam sistem integrasi, dan semuanya itu akan terintegrasi melalui platform Satu Sehat yang dikelola oleh Kementerian Kesehatan. Namun perlu diingat bahwa integrasi ini karena datanya cukup besar dan datanya mengandung data-data individu, maka kami sangat comply terhadap perlindungan data pribadi sesuai dengan Undang-Undang Nomor 27 Tahun 2022. Dan tujuan dari interoperabilitas data ini pemanfaatan data untuk analisis kebijakan, perencanaan strategis, dan pengambilan keputusan berbasis bukti. Ya. Ini contoh-contoh integrasi data dengan Kementerian Kesehatan. Yang pertama akan kami sampaikan melalui integrasi sistem. Jadi di sini ada penyambungan antara sistem atau aplikasi yang ada di BPJS dan di Kementerian Kesehatan. Jadi sistem BPJS terintegrasi aktif dengan platform aplikasi Kementerian Kesehatan. Dengan metode ini, maka aplikasi Kemenkes dapat mengakses data secara real time ke dalam master data BPJS Kesehatan. Data yang dapat diakses ini antara lain data profil peserta, data Vaskes atau fasilitas kesehatan, riwayat kesehatan, tenaga kesehatan, dan sebagainya. Salah satu contoh ini adalah integrasi SINAF, ini milik Kementerian Kesehatan, dan Hafiz itu Health Facilities Information System dengan BPJS. Ini terintegrasi untuk mengintegrasikan data-data fasilitas kesehatan. Jadi di sini kalau nama, kelas rumah sakit, alamat itu kalau tidak sama antara data yang ada di BPJS dan Kemenkes ini akan terdetek melalui integrasi ini. Yang kedua, integrasi kepesertaan aktif SITCK. Ini untuk mengecek status kepesertaan JKN. Jadi ini adalah sistem informasi tenaga cadangan kesehatan. Ini kalau mau mendaftar atau registrasi, maka di situ aplikasi ini akan mengakses master data di BPJS apakah yang bersangkutan sudah terdaftar sebagai peserta JKN. Kalau sudah terdaftar, apakah aktif atau tidak. Ini sehingga akan ketahuan secara real time. Kemudian integrasi kepesertaan aktif SIKN. Ini untuk tenaga kesehatan yang ada di aplikasi Kemenkes sama untuk mengecek status kepesertaan JKN. Kemudian ya ini yang penting ini PKG, pemeriksaan kesehatan gratis. Jadi setiap masyarakat yang akan melakukan cek kesehatan gratis ini akan terdetek apakah yang bersangkutan sudah terdaftar JKN. Kalau sudah terdaftar apakah aktif gitu, meskipun tidak menghalangi untuk mendapatkan CKG, namun diharapkan kepesertaannya aktif. Kenapa? Karena apabila dari cek kesehatan tersebut ada indikasi penyakit, maka kepesertaan JKN-nya atau kartu JKN-nya bisa dimanfaatkan untuk tindak lanjut pemeriksaan ke fasilitas kesehatan. Dan yang ini paling baru, ini integrasi kepesertaan aktif SISKO-HADKES, ini sistem komputerisasi haji terpadu bidang kesehatan. Ini jadi untuk masyarakat yang mendaftar haji, maka aplikasi Kemenkes akan mengakses data BPJS selain kepesertaan. Ini secara khusus ada riwayat kesehatan tertentu atau riwayat penyakit tertentu, khususnya penyakit-penyakit katastrofi. Sehingga ini bagus banget untuk mempersiapkan kondisi calon haji tersebut kalau memang yang bersangkutan mempunyai riwayat penyakit-penyakit tertentu yang aplikasinya dapat diakses real time ke dalam master BPJS. Metode kedua adalah API. BPJS Kesehatan menyediakan akses API agar sistem informasi kesehatan dapat terhubung dan melakukan sinkronisasi data dengan platform Satu Sehat. Ini pemberiannya secara rutin periodik, biasanya bulanan, ada yang semesteran. Ya, ini yang lebih banyak menggunakan ini iklim-viklim, ini misalnya ini di rumah sakit. Semua rumah sakit yang bekerja sama dengan BPJS menggunakan integrasi aplikasi ini. Iklim itu aplikasi dari Kemenkes, Viklim itu aplikasi dari BPJS. Jadi pada saat rumah sakit melayani pasien itu akan mengakses master data BPJS, kemudian mengajukan klaim itu akan mengakses aplikasi Inasibijis milik Kementerian Kesehatan. Nah, yang sedang dikembangkan sekarang itu rekamedik elektronik. Ini nanti pada waktu pengajuan klaim diharapkan nanti sudah menggunakan RNE sehingga ini nanti pengajuan klaimnya akan lebih cepat dan lebih akurat. Yang kedua ini JKN Claim Verification Status. Jadi kita juga mengirimkan API ke Kemenkes pasien-pasien atau klaim yang sudah diverifikasi oleh BPJS. Kalau yang klaim tadi baru pengajuan saja. Nah, hasil verifikasi dari BPJS ini dikirim ke Kemenkes melalui API. Ya. Kemudian National Health Account ini semesteran, ini data pembiayaan. Ini datanya besar sekali. Dan ini digunakan untuk analisis dan pengambilan keputusan. Kemudian data tuberkulosis ini datanya berupa data individu ya, masing-masing kasus. Ini setiap bulan data tersebut kita kirimkan ke Kemenkes. Kemudian metode selanjutnya ada analytical platform. Kami menyediakan dashboard dan self-service business intelligence. Jadi Kementerian Kesehatan memiliki akses analitik mandiri ke data BPJS Kesehatan melalui dashboard dan SSBI. Jadi dashboard ini memberikan gambaran kepesertaan, fasilitas kesehatan, dan utilisasi pelayanan yang terupdate. Jadi secara otomatis periodik ini akan terupdate sehingga data yang ditampilkan lebih cepat dan mudah dimanfaatkan langsung oleh Kementerian Kesehatan. Kemudian SSBI ini penyediaan dataset, jadi ini raw data, sehingga Kementerian Kesehatan dapat mengolah dan mengakses dan mengolah secara mandiri raw data BPJS Kesehatan, dan nanti bisa digunakan sesuai dengan kepentingan dari Kemenkes. Kemudian ada Applicares, ini aplikasi yang menunjukkan fasilitas kesehatan yang kerjasama, dan ini berupa peta di mana ada warna merah, hijau, kuning, dan warna-warna ini menunjukkan kebutuhan fasilitas kesehatan. Yang merah itu kami membutuhkan. Yang hijau itu sudah tidak membutuhkan lagi, sehingga ini bisa digunakan untuk strategi perencanaan pengadaan atau pembangunan fasilitas kesehatan di suatu daerah. Ya. Untuk selanjutnya kami akan sampaikan tentang dashboard JKN. Jadi dashboard JKN ini kita buat, jadi BPJS Kesehatan telah mengembangkan atau membuat dashboard JKN ini yang khusus digunakan oleh pemangku kepentingan untuk melakukan analisis data terhadap pelaksanaan program JKN. Data dan informasinya meliputi kepesertaan, contohnya capaian UHC, Universal Health Coverage, fasilitas kesehatan, pemanfaatan pelayanan kesehatan, dan secara rutin nanti kita update. Dashboard ini kita sediakan mulai tahun 2022, dan ini diberikan kepada seluruh pemerintah daerah. Jadi pemerintah daerah provinsi, kabupaten, kota, seluruh Indonesia kita berikan aksesnya. Dan aksesnya itu melalui biasanya Dinas Kesehatan, karena kami koordinasinya dengan pimpinan daerah. Biasanya pimpinan daerah itu akan mendelegasikan kepada Dinas Kesehatan. Ya, setiap daerah, kabupaten, kota itu mempunyai username password sendiri, dan mereka hanya bisa mengakses untuk data-data di daerah mereka sendiri, kecuali untuk data Universal Health Coverage, itu bisa melihat seluruh Indonesia. Selain pemerintah daerah, dashboard ini juga kami berikan akses ke Kementerian Kesehatan, OJK, BPK, Kemenko PM, dan beberapa kementerian yang lain yang memang mempunyai kepentingan ya untuk mengakses data ini, dan siapapun nanti kementerian lembaga ini masih juga ada beberapa yang mengajukan, nanti kami akan berikan aksesnya. Ya, ini tampilannya mungkin Bapak Ibu yang karena sudah mulai tahun 2022, jadi Bapak Ibu Dinas Kesehatan mungkin sudah familiar ya dengan dashboard JKN ini, dan kami bisa memantau daerah-daerah mana yang aktif memanfaatkan dan mana yang kurang mengakses ya. Dan biasanya kami akan mengundang dinas kesehatan yang aktif menggunakan dan kami akan ajak mendiskusikan apalagi kebutuhan data yang dibutuhkan di daerah. Karena ini bagi daerah-daerah yang sudah mengakses ini sangat besar manfaatnya. Jadi ini bisa menampilkan capaian universal health coverage, profil peserta JKN, kemudian fasilitas yang bekerja sama di daerah tersebut, utilisasi pelayanan, data diabetes mellitus, hipertensi, penyakit katastrofi, penyakit menular, misalnya TB, ini bisa dilihat sampai kecamatan. Jadi Bapak Ibu bisa melihat masyarakat di wilayah kerjanya berapa yang terinfeksi TB ini sampai ke kecamatan. Ini yang baru, ini ada data tentang mental health dan ketersediaan obat. Jadi daerah-daerah mana yang kosong, terjadi kekosongan obat, di situ bisa dilihat, dan KIA. Ini yang terbaru karena request dari beberapa daerah. Ya. Salah satunya di sini yang terkait dengan tema di HKN ini adalah penyakit katastrofi. Di sini ada beberapa data, salah satunya stroke. Nanti kami akan sampaikan gambarannya seperti apa. Ya. Nah, ini salah satu contohnya ya. Ini dashboard Universal Health Coverage. Ini bisa melihat kalau ini data secara nasional, capaian kita 98,68% dan setiap provinsi nanti bisa melihat punyanya masing-masing. Kabupaten kota juga bisa dilihat dan periodenya kapan. Dan ini segmennya apakah dari Mandiri, dari PBI, bisa kelihatan dan progresnya dari bulan ke bulan. Kemudian kalau diklik yang gambar peta ini, gambarannya seperti ini. Nah, ini angka nasional. Di sini petanya akan kelihatan mana yang sudah universal health coverage atau lebih dari 95%. Kalau kuning ini 90 sampai 95% dan yang merah itu kurang dari 90% ya. Ini alhamdulillah nggak ada yang merah. Kalau kita lihat dari bulan ke bulan yang lalu masih ada 1-2 yang merah, tapi ini sebagian besar sudah hijau. Ya, ini contoh yang lain, ini fasilitas kesehatan. Ini Bapak Ibu bisa melihat provinsi mana, misalnya itu berapa jumlah FKTP-nya, berapa rumah sakit atau vaskes rujukan, dan berapa penunjang. Ini ada apotek, optik, dan fasilitas penunjang lain. Dan di sini atas request juga dari daerah kita tambahkan data peserta terdaftar. Jadi ini misalnya contoh di kanan bawah ini puskesmas X, nanti peserta terdaftarnya jumlahnya berapa. Nah ini harapannya ini sangat ya dimanfaatkan. Kami sudah menyediakan ini dengan sangat berharap pakailah data-data ini untuk membuat kebijakan di daerah. Ya, ini dashboard.
Maaf Bu, 1 menit lagi ya.
Baik, sudah selesai ya. Nah, ini untuk katastrofi, ini salah satunya ini stroke, ini kasusnya ini sampai bulan ini ya 2025 ini ternyata laki dan perempuan ini hampir sama ya, tapi umur 0 sampai 0,5 tahun ini ternyata kok ada ya kasusnya. Ini tergantung input data oleh fasilitas kesehatan ya. Ini kemudian kami juga menyampaikan ini penting Bapak Ibu karena ada peserta dari akademisi, kami menyediakan data sampel ini untuk digunakan untuk penelitian. Total ini 102 juta, ini data yang sangat besar, silakan bisa diakses tanpa biaya. Ini ada data diabetes, tuberkulosis, KIA, dan terbaru itu mental health. Dan ini caranya adalah mengakses data.bpjskesehatan.go.id. Nanti di situ ada persyaratan, maka Bapak Ibu bisa mendownload data-data tersebut digunakan untuk penelitian dan untuk pengambilan kebijakan. Itu dari saya sebagai kesimpulan bahwa jadi untuk interoperabilitas data JKN dilakukan dengan berbagi, bertukar, dan menggunakan data secara terintegrasi sehingga berbagai pihak dapat mengakses, memproses, dan memanfaatkan data secara otomatis dan akurat untuk meningkatkan efisiensi, kolaborasi, mempercepat alur kerja, serta melakukan analisis kebijakan, perencanaan strategis, dan pengambilan keputusan berbasis bukti. Ada dua hal yang menjadi tantangan kita adalah keamanan data. Data besar mengandung data individu, ini harus kita jaga bersama, dan literasi data yang masih kurang. Karena kami menyediakan data akses yang begitu mudah dan sangat penting ini, tapi masih sedikit yang mengakses karena kami memonitor yang mengakses dashboard-dashboard atau data-data kami. Demikian, terima kasih, waktu saya kembalikan. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Dwi, for your presentations. I think it's very insightful to see that BPJS already had a lot of data that is available also for the public to be used, especially for the health sector, to be utilized for further policy making. And hopefully, after this webinar, people will start using it and utilizing it. Also, there is several possibility of possible collaborations between ministry that can be made. Previously, there is BPS also with Ministry of Home Affairs. I think it will be great for us to collaborate further for developing system to further measure the burden of disease of data in Indonesia. Now we are opening the floor for a question and answer. For now, there are two questions. First, for Dr. Dwi, how does BPJS integrate its administrative health data with national burden of disease datasets to ensure consistency and completeness, especially for conditions like stroke that require long-term care and follow-up? Please respond, Dr. Dwi. Over to you.
Ya, terima kasih ini atas pertanyaannya. Jadi BPJS ini sudah terintegrasi ya dengan data-data di Kementerian Kesehatan dan kasus-kasus burden disease itu semuanya sudah ada, dan kami tadi sampaikan bahwa SSBI Self Service Business Intelligence itu diantaranya berisi tentang dataset pasien-pasien penyakit ini, sehingga ini untuk diolah, diakses oleh Kementerian Kesehatan bisa dilakukan secara mandiri. Namun tentang long term care ini memang sedang kita bangun ya, ini beberapa penelitian analisis data sedang disiapkan oleh bagian riset kami, dan tentunya nanti ke depannya harapannya akan dimasukkan ke dalam salah satu kebijakan di Kementerian Kesehatan ya, kalau memang itu menjadi salah satu benefit. Kalau saat ini long term care belum masuk dalam benefit dan belum ada tarifnya, sehingga BPJS memang belum bisa melayani untuk khususnya long term care gitu. Kita harapkan memang dalam waktu dekat, karena saat ini sedang berproses, nanti bisa dijamin dalam program jaminan kesehatan nasional. Izin, saya bisa lanjutkan pertanyaan yang kedua yang di bawah ini tentang CKG.
Yeah, please continue.
Ya. Jadi ini pertanyaannya, saat ini Kemenkes menjalankan program cek kesehatan gratis yang sebelumnya terintegrasi dengan Sehat Indonesiaku dan kini memiliki dashboard tersendiri. Di layanan primer, petugas masih harus melakukan entry data 2 kali di sistem CKG dan juga di aplikasi CKN BPJS. Apakah ada rencana atau roadmap konkret menuju interoperabilitas penuh antar sistem tersebut agar data cukup diinput sekali namun bisa dimanfaatkan lintas platform untuk efisiensi dan pengambilan kebijakan di tingkat daerah? Ya, jadi yang sudah terintegrasi secara aplikasi memang tadi Vclaim dan eClaim itu aplikasi yang ada di rumah sakit. Untuk aplikasi di tingkat primer, ini aplikasi BPJS ini namanya Picare. Ini memang belum terintegrasi dengan aplikasi di Kementerian Kesehatan. Namun saat ini sedang proses. Jadi di bagian kami, namun di bidang yang lain itu di bagian sistem itu sedang bersama-sama dengan Kementerian Kesehatan untuk mengintegrasikan sistem ini. Jadi artinya ini sedang dalam proses. Demikian, Pak, kami kembalikan.
Okay, thank you, Dr. Dwi. And now there is a question from Nikma from Surabaya to Ibu Vina. Ibu Vina, the floor is yours.
Okay, thank you, Mas Yando. Since the question is in Indonesia, and I will answer in Indonesian too. Ya, Bu Nikma bertanya, ada penelitian dari KKS. Izin, saya kurang familiar dengan istilah KKS, kemudian PTM dan lain sebagainya. Jadi saya menjawab berdasarkan asumsi saja ya. Intinya bahwa ada inisiasi tentang policy brief yang mau inform gitu ya kepada government gitu. Sejauh ini kalau kita mau membuat policy brief dari akademia atau dari bukan organik dari government gitu ya atau dari Pemprov dalam hal ini biasanya kita sepakati dulu gitu ya dari sebelum membuat penelitian atau policy brief gitu. Jadi kalau cuma sekadar menginform sih harusnya diterima, tapi apakah itu menjadi joint research atau enggak? Kalau misalkan dia independen, tapi kalau misalkan mulai dari planningnya, kemudian mendefinisikan atau tujuan objektif daripada penelitiannya, kemudian policy briefnya. Kalau untuk government kan dia memang harus melihat dulu gitu ya, di-align-kan atau diselaraskan dengan program-program yang sedang dilakukan oleh Pemprov Jatim. Jadi kalau saya melihat di sini sudah dilakukan penelitian, policy brief, kemudian mau disampaikan atau masih mau memulai nih. Nah, ini yang saya masih belum bisa menangkap pertanyaan dari Bu Nikma ini. Tapi sejauh ini ketika BPS mau ada joint research itu dari awal gitu, bukan ketika sudah selesai, sehingga ini bisa menjadi produk yang dipakai dan align dengan tujuan-tujuan atau program-program strategis dari government, Pemprov ataupun juga BPS. Mudah-mudahan menjawab Bu Nikma. Kalau misalkan belum terjawab, mungkin bisa kontak saya melalui email. Demikian Mas Yando, terima kasih.
Thank you, Ibu Alvina. There is one more questions to BPJS, I think, for Ibu Dr. Dwi. Apakah mekanisme pembagian data yang dilakukan selama ini bersifat satu arah? Hanya BPJS yang menggunakan data kepada pengguna user, ataukah ada kebijakan yang memungkinkan penerapan mekanisme pertukaran data dua arah? Misalnya BPJS Kesehatan dengan BPS, misalnya untuk DTSen. Apakah ada mekanisme seperti ini gitu? Over to you, Dr. Dwi.
Ya, baik. Jadi interoperabilitas data ini bisa beberapa macam ya. Jadi contohnya kalau tadi dicontohkan data sen, ya, data set, data sen ya, artinya data dalam jumlah besar itu memungkinkan untuk melakukan pertukaran. Jadi kita itu sampai dengan saat ini ada 40 kementerian lembaga. Jadi ada Kementerian Kesehatan, Kementerian Sosial, Kementerian Dalam Negeri, Kemenko PM, dan banyak sekali. Dan itu pada saat interoperabilitas data ini ada kontrak, ada perjanjian kerjasama yang di situ akan diatur nanti salah satunya misalnya data yang akan dipertukarkan Kemudian keamanan data, karena BPJS ini sangat comply terhadap Undang-Undang Perlindungan Data Pribadi, sehingga sesuai dengan undang-undang tersebut, kami pada saat melakukan interoperabilitas data itu pastikan bahwa yang akan interop atau integrasi dengan BPJS itu mempunyai sistem keamanan yang sama atau sepadan gitu. Barulah itu akan terjadi interoperabilitas data. Jadi saling memanfaatkan data, saling tukar menukar data, dan di situ nanti biasanya dari kontrak itu nanti akan ada lampirannya. Nah, lampirannya ini data apa saja yang akan dipertukarkan dari BPJS apa, dari kementerian lembaga tersebut apa. Seperti itu. Jadi sangat memungkinkan sesuai dengan kontrak yang disepakati bersama. Terima kasih.
Thank you, Dr. Dwi. I hope the answer is clear for you. We have one person here raising the hands before. Ibu Helmi Diana, are you still willing to ask something? Ibu Helmi Diana, or you already put your hands down now? Do you still want to talk before we end these sessions? Okay, we've got no answer, but thank you for all of our nice speaker here. Very much information that we got today. Hopefully this not end here. Hopefully between us we will follow up with a lot of discussions and meeting to further and discuss between us how to develop the system to further calculate the burden of disease of Indonesia. Hopefully this will bring Indonesia into a greater country, make Indonesia really can reduce its burden of disease and help Indonesia to allocate better funding for health matters. I think that's all from me. Thank you everyone for your presentations today. Thank you also for all of the people that's attending. I see here 277 people still following us. Thank you so much. And I will give the floor back to Ibu Riana. Over to you, Ibu Riana. Thank you very much.
Okay, thank you to all panelists and the moderator for the insightful exchange. Now to conclude today's webinar, we will now listen to the webinar summary and closing remarks by Bapak Lupi Tilaksono, SFMM APT, Director for Health Research System Policy. Bapak Lupi, the screen is yours.
Yes. Do you hear my voice well reception?
Yes.
Okay. Thank you. Yes. Very good afternoon, everyone. Thank you so much, distinguished speakers, honorable guests, esteemed colleagues, ladies and gentlemen. On behalf of the Health Policy Development Agency, I would like to express my highest appreciation to all distinguished speakers from the World Health Organization, the Institute for Health Metric and Evaluation, the National Institute for Stroke and Applied Neurosciences, Auckland University, the Vital Strategies, the World Stroke Organization, and our national expert for sharing their valuable insight and experiences with us today, from the morning until the afternoon. Throughout this event, we have gained a deeper understanding of how burden of disease data, particularly in the case of stroke, can guide evidence-based decision-making and strengthen Indonesia health system transformation. The discussion have provided important perspective on translating data into the policy action, ranging from the prevention and early detection to improving treatment and referral system. And also, I would like to extend my sincere gratitude to all moderators, participants, and the organizing committee for their commitment and the contribution to the success of this webinar. The active participation and exchange of ideas during the session demonstrate our shared dedication to advancing health data utilization and improving public health outcomes. It is our collective effort that the knowledge and the recommendation generated from the two-day discussion will serve as strong foundation for the formulation of more targeted, data-driven, and impactful health policy in Indonesia. Let's make this collaboration continue beyond this webinar and then fostering ongoing partnership between the policymaker, researcher, practitioner, and also the international organization. Once again, thank you so much for your active participation and continued support. May today even inspiring all of our effort toward the achieving a healthier, stronger, and also the resilient Indonesia health system. Once again, thank you very much. Dan wassalamualaikum warahmatullahi wabarakatuh. Terima kasih Bapak Ibu sekalian.
Terima kasih Pak Kapus.
Terima kasih Bu Sri, Bapak Ibu sekalian.
Terima kasih Pak
Bu Dwi.
Kapus. Terima kasih
Terima
semuanya.
kasih Pak Yando.
Bapak Ibu peserta silakan mengakses X-link-nya. Boleh diumumkan ya Mbak Raina.
Ya, baik. This is the end of our international webinar. Before we officially close, we would like to kindly remind all participants to complete the survey and please scan the QR code on the screen. And we would also like to inform that the learning management system is now open. So for those who already registered and want to receive a learning hours and certificate, please access link on the chat or shown on your screen. Thank you for your participation. Stay safe, stay healthy, and have a wonderful day.
Dan ikuti.